Post removed and I joined again. Maybe by mistake. I
No,
don't know.
very sorry, sir. We did not remove you, sir. Very sorry.
We cannot remove you, sir.
No. I know Srinivasan and Karangavellu and everyone here, but I'm just telling the technical things what suddenly.
Okay, sir. Okay.
Dr. Ajay Khanna sir, namaskara. Namaskara Ajay Khanna sir and Shaji Thomas.
Okay, good evening, everyone. In the meantime, let others join. I warmly welcome for
the other girl has joined, sir. You can ask her to share this. Zarin, can you share your slide? Dr. Zarin?
Yes, sir. Just a second.
Yeah, you just share this, run through the slides. So if you have any problem, we can.
Yes, sir. So can you see?
No, only the parotid tumor seen. You're not share. It does not come.
Just open the screen.
I have opened the screen, sir.
Wait for some time.
No, she is seeing it.
It takes some time.
You bring it to the desktop, open it, then you share screen. You stop share now. Bring it to the desktop. Open it. Sharad Desai sir, namaskar. Sir, unmute, sir.
Thank you for joining, sir. Sharad sir. Good evening, sir. Sir, you are in mute mode, sir.
Oh,
go to the slideshow. Go to the
Thank you, sir. Thank you for joining, sir.
Yeah,
thank
you.
Yes, sir.
Zarin, your slides are good to go. Can you just run through the slides just to check everything is in order?
Okay, sir.
Okay. Thanks, Kana. You can now unshare.
Unshare, sir.
Yeah, please unshare.
Okay.
Good evening, friends. We have yet another important edition of the PG clinics. I think this will be the 5 o'clock last clinics. Then we are moving to 8 o'clock time soon from the next week onwards. So I thank one and all, Dr. Vivek sir, Dr. Ajay Khanna sir, Dr. Raj Gopal sir, and Dr. Srinivasan sir. And we welcome the faculty for the day, Professor Shaji Thomas from RCC Trivandrum. Again, thanks to Srinivasan sir for getting the introduction. And Professor Dr. Sharad Desai sir from Neeraj. Sir is the Honorary Secretary of the Indian Association of Surgical Oncology, and he's been kindly accepted to join us. And we have our always ever supporting Professor Sumati Madam. Professor Sumati Madam right now is a Professor of Surgery at Mohan Kumara Mangalam Medical College. And we thank for her all the support being given for giving regularly PGs and cases for presentation. Now we have the honor of having 3 faculty today. And we have 2 PGs, one from Dr. Srinivasan sir's institution with CA Kang, and then we have Dr. Zarin from Grant Medical College, Mumbai. So warm welcome to PGs, warm welcome to faculties. Now I request Dr. Kapil Manohar to share his presentation. The priority goes to the invited guests for the day, then the scientific committee people can ask questions. Kapil, please start.
Yes, sir, I'm sharing, sir.
Kapil, you just before that you just introduce yourself and
yes, sir,
MSPG.
He's introduced in the slide, sir.
Oh,
okay. He's the 3rd year PG of Coimbatore Medical College.
Oh, okay.
Yes, sir.
Good evening, respected faculties. Good evening, Kanangvel sir, all the faculties across India, invited chief guest, Suji sir, and all my colleagues. I thank Professor Dr. Srinivasan sir, my guide, for helping me prepare this presentation. I also thank my unit assistants, Dr. Gunala Suresh sir, Dr. Veeradan sir, for guiding me in academic activities. My presentation today will be about a tongue lesion. Can I start presenting, sir?
Yes, definitely.
A 56-year lady who is an housewife belonging to low socioeconomic status presented with complaints of ulcer over the left side of tongue for 2 months duration. and associated pain over the ulcer for 2 months duration. Patient was asymptomatic 2 months back when she noticed an ulcer over the left lateral aspect of the tongue that was insidious in onset. Ulcer was initially 0.5 into 0.5 centimeter, which then gradually progressed to attain the present size of 3 into 2 centimeter. Ulcer was associated with pain, which gets aggravated on taking hot and spicy food. There is no history of restriction of mouth opening or tongue movement, no history of difficulty in speech, no history of difficulty swallowing, no history of earache, no history of repeated trauma from sharp tooth or dentures, no history of recent loosening of tooth, no history of any swelling in the tooth, no history of any high risk sexual behavior.
Why do you specifically ask for that? High risk. Does it?
Sajid Thomas, sir.
I didn't
Well,
ask.
we'll finish.
We'll
on
finish
that.
the history, sir. Then we'll
Okay.
then we'll stop him, sir. Sorry to.
Past history. There is no previous history of ulceration, whitish or reddish patch in the tongue. No history of previous surgeries in the past. No other comorbidities. Personal history. Patient is a known tobacco abuser since past 10 years. On mixed diet, but recently takes only bland diet as pain gets aggravated on taking spicy food. Sleep is undisturbed. Bowel and bladder habits are normal. Obstetric history. Patient is para 2, live 2, normal vaginal delivery. Family history. No history of cancer-related death in the family. Summary. A 56-year-old lady who is a tobacco abuser with no known comorbidities presented with ulceration over the left lateral aspect of tongue for the past 2 months duration, which was gradually progressive and associated with pain.
Go to the first slide, pa. Saji sir and Sharat sir, please.
Nice presentation, Kapil. Actually, I wanted to know what do you suspect when a patient comes with an ulcer associated with pain?
Usually, it will be after ulcer, sir, which is painful, and it resolves within 1 or 2 weeks, sir.
Malignant ulcers won't be painful.
Initially, malignant ulcers will be painless, sir, but as it advances, it gets painful, sir.
What is the usual radiation of pain in tongue ulcers?
There can be radiation to ipsilateral ears, sir.
Okay.
Can you tell what are the various painful ulcers of the tongue and what are the various painless ulcers of the tongue?
So painful ulcers are tuberculous ulcers and aphthous ulcers, sir. Painless ulcers, example syphilitic ulcers over the tongue are painless, sir.
Traumatic ulcers?
Traumatic ulcers are painful, sir.
Dental ulcers?
Actually, Kapil, I would just suggest that you are going through something a very odd area. When you say painful ulcers and when you are suspecting malignancy, then there is something not very conducive. Most of our patients, they interpret pain as anything. When they want to complain something, they usually say it as pain. So you should not try to avoid putting it in front of the examiners. So you can just say ulcer of the tongue with discomfort. Because when you say pain, then again, some examiner can be very cranky and he can keep on asking questions. And because most of the malignant ulcers are supposed to be painless. Okay. So, so you will have to be a little careful when you are using the words. Nothing wrong probably because I know most of our patients who are not very educated, they just keep on interpreting their symptoms in different ways. So like sometimes they may say, just because they want to catch the attention of the doctors, they say it's painful. Most of the time it's usually painless. Okay.
Okay, sir.
And that is why if it would have been painful, he would not have allowed it to grow from such a small size to such a large size. He would have come early.
Okay, sir.
Is there any bleeding from the ulcer? Any history of bleeding?
Sir, at the time of brushing, the patient experienced some bleeding from the ulcer, sir.
Okay, that's.
Oh, okay.
Go to the next.
Okay, you can proceed.
So can you hear me?
Can I go with the examination part, sir?
Sumanti madam, you want to ask anything, madam?
Yeah. So when a malignant ulcer, when it will become more painful? Even though patient has an ulcer for a 2 months period, patient comes to the hospital at a later time. We see all malignancies, patient coming at the later stages. Why it is happening? When the patient in a malignancy will have pain. Generally, as I told, well, malignant ulcers will be painless. But sometimes what happens when the patient has infiltration into the nerves or because of a secondary infection, patient will have pain, no? In advanced disease, patient will have pain at all.
Definitely, when it's deeply infiltrating.
I agree with you. When there is deep infiltration,
it falls into the lingual nerve or the adjacent tissues, the patient will develop pain. So, when you are
Glossopharyngeal.
ulcer and the duration of the pain, whether it is same or the ulcer started before and the pain came later.
Initially, there was only ulcer, madam. Later, only pain has set in.
That is why sir is telling, see, you put both of the same duration.
Yeah, given in same duration.
Same duration. Madam is also asking, will it occur simultaneously? That was the question, sir. Desai sir said, you said discomfort rather than telling it is pain.
Okay, sir.
Patients develop pain for the past 1 month or 15 days, you can say.
Okay.
Only
This is
because
what
of
madam
the
is
pain,
also
patient
telling.
has come to the hospital. If the
Is
patient
there
has not pain at all, no, the patient would have not come at all.
Is there any excessive salivation from the oral cavity? Usually one symptom many patients complain about oral ulcers, especially malignant ulcers, excessive salivation.
Go to the next slide, Pa.
Yes, sir.
Did you mention that one?
I didn't mention that, sir.
But,
But,
okay, just for completion, I'm telling, not this. Okay, you can proceed.
That's a classical saying, no, sir. A patient sitting in the OP with the handkerchief over the mouth.
And spitting in between.
He's spitting in between. So that is a classical feature of it.
Salivation is from the growth.
Sir, anything in the history?
Kapil, can you tell us what is the cause of this excessive salivation?
One is the patient has difficulty in swallowing, sir. One is due to constant irritation of the ulcer. There is excessive salivation.
So basically, it's because of difficulty in swallowing. The saliva collects in the mouth. Irritation part we don't see because we don't see the same kind of excessive salivation in say buccal mucosa or hard palate or something. It's basically because they collect the saliva in the mouth.
Okay, sir.
What do you mean by tobacco abuser? No, you have written in your personal experience.
Go to the previous
known
slide.
Tobacco abuser since past. What does that mean?
Sir, she's chewing the pan masala and the Hans, the tobacco powder, like a
Better to say habit of tobacco chewing or a bit of taking tobacco.
No, you have to be very specific.
Yeah.
Because tobacco may be of different types. Okay, somebody may be smoking, somebody may be chewing, somebody may be putting the quid, somebody may be taking the pan, somebody may be taking with the other things which are there, or the reverse smoking is there. So there are so many types of the tobaccos which are there.
Just
what is reverse smoking, you know? What is reverse smoking?
Sir, not sure, sir.
Have you heard about the surtu in Tamil Nadu, no?
Yes, madam.
Cigar. That will be in a rolled model. Both the ends will be open. So if the patient smokes, no, that will be like reverse smoking. It goes inside and that makes more of oral submucosal fibrosis and oral problems. The
Palatal
mucosa
cancer. Okay, palatal cancer is very
more
common.
More about the reverse smoking.
and the lip malignancy, the cancer in the lip is more common in these patients.
Okay.
Kissing ulcers.
And this tobacco abuse, the tobacco quit all things, no, or what material they are using is more important. And the duration, how long they keep it in their mouth for how many duration they keep it, and how long it is there. Have you
Okay.
given about the movement of the tongue?
The inspection is not come.
Yes, no, just history alone. History alone is complete.
Saji sir, you asked one question about high risk behavior.
Okay.
Go back over.
Usually, people won't describe this high risk sexual behavior. Why he specifically
Kapil, go to the
mentioned it?
Srinivasan, can I ask questions, sir?
Sir, please, sir. You can. I am just country. Shaji wanted this one.
Yeah.
Okay.
For high risk behavior, Saji sir asked a question.
Because usually PGs won't give this history, take this history. Why I am just asking why he has taken
I didn't
specific
ask,
history.
Detailed history. I just asked whether she had any coitus activities in the recent times, but I didn't go into the intricacies of all this.
So you can omit that
word. Or did you keep the possibility of HPV infection or something in mind?
Yes, human papilloma infection.
Okay.
Chennai sir, please.
Okay,
Sir.
good. Proceed.
Dr. Kapil.
Yes, sir.
Can you tell me some various presentations of carcinoma of the tongue? This patient has come with a lesion in the tongue, but what are the different ways they can come to your OPD and they can present so that you may get bowled by them? What are the ways? One is an ulcer. Okay,
yes.
Classical lateral border. Yes. Next.
It can be induration type, a warty type.
Don't be in a hurry to jump now. Clinical presentation. I did not ask you about induration, which is examination. Clinical.
Okay.
They will come and show you, okay, I have got a lesion. That is the first way. Classical way. Any other way?
Swelling over the tongue.
Yeah. Swelling. Better use the word ulcerative lesion, especially I asked you malignancy. Okay. When you say swelling, can be hemangioma, lymphangioma, gamma, so many things. Let us not confuse the matter. Okay, one is an ulcer for which this patient has come. And
yes.
Laterally, you nicely put when you take hot fluid and all that chilly, you get definitely irritated. It's a sensitive mucosa because it is richly supplied by the nerve endings there. Okay, so
yes,
one is about a ulcer which is non-healing. You should use the word non-healing. Okay, don't try to use 0.5 centimeter and 1.5, 2.75, 3 like that. So examiners will get also small in size, madam, gradually increased it in the present size. That is fine.
Okay.
One is ulcer. Second is the bleeding. You should tell bleeding. Okay, trauma. Trauma is one of the sites where oral cavity you can get. Any other presentations?
Sir, swelling in the neck, sir.
Very good. Which classically it happens even when a lesion is small. Patient may not tell you about the lesion at all. Even when you examine, you may not find a lesion in a cursory examination, but you will find bilateral neck nodes. What condition is that? I have given you the clue. Carcinoma posterior 1/3 of the tongue.
Yes, sir.
Why it is more common in posterior 1/3 for a bilateral spread? Usually.
So midline structures, there will be bilateral drainage.
Not midline. There is a lot of lymphatic, crisscross.
Base of tongue is a very rich in lymphatics.
Posterior 1/3, whatever base sirs just now told, rich in lymphatics, crisscrossing is there. So they can just come and show you posterior nodes, and you just say, open the mouth. You may not find the lesion unless you really carefully examine it. That will come to later. That is the next presentation. A lot of discussion came on about the drooping of the saliva and all that thing pouring out. It can happen when you are not able to swallow. Is it clear? See, if you are able to swallow, you try to swallow and see. You can swallow your saliva. Tell me which growths. This phenomenon is very common. Spitting, all the time spitting, and they can't swallow also. When the
growth in the posterior,
commonly posterior, and when the tongue has lost its mobility. See, the most important thing is you need the tongue to push that fluid or bolus, against the palate there. Then only you can swallow. So any posterior third lesions or even any cause for the restriction of the tongue mobility, including anterior two-thirds there, fix it in the floor of the mouth, etc. So they can present with an ulcer, they can present with the bleeding, they can present with the neck nodes, they can present with the, just now we talked about dysphagia. What is disarticulation?
The quality of speech will be altered, sir.
So did you mention that?
No, sir, I haven't mentioned it.
You should mention, okay, this is the lateral lesion. I
Okay.
agree that it may not cause in your patient, but that should be a habit. Can they come with a recurrent respiratory infection?
Yes, they can present with the recurrent URIs because of.
In other words, you should be ready with the all these types of questions which examiner may ask you. And whenever,
aspirations.
Sir, yeah.
Aspiration, patient develops bronchopneumonia, recurrent infections.
So
Apart
especially,
from this, have you asked about the halitosis, the fetal smell from
in
the
inspection part, I have mentioned
He
about.
has not come to the inspection, to the examination. Yes, proceed, Kabil.
Yes, sir.
You go to the inspection, Saji sir.
Yes, definitely. Proceed.
Clinical examination.
Physical examination. I have examined the patient with informed consent in a well-lit room with adequate exposure in the presence of family attendant. Patient is conscious, coherent, and cooperative. The BMI of 22. Hydration status well maintained with ECOG score of 1. There is no pallor, icterus cyanosis, clubbing, or generalized lymphadenopathy or pedal edema. Pulse rate is 78 per minute in right radial artery. Normal volume, regular rhythm. BP is 120/80 millimeters of mercury in the right arm. Supine position. Patient is afebrile with a respiratory rate of 14 per minute. This is a clinical picture of the patient. On inspection, the mouth opening is adequate. There is no halitosis. Facial symmetry is maintained. There is no deviation of tongue. Tobacco staining of the tooth is noted. An ulceroproliferative lesion noted over the left lateral border of anterior two-thirds of tongue, measuring about 3 into 2 centimeters. The lesion is about 1 centimeter proximal to the tip of tongue and 1 centimeter from the midline. The borders are irregular and everted. There is surrounding edema noted. There is no involvement of floor of mouth. There is no swelling or ulceration noted in the posterior one-third tongue. The tongue movements are normal. Rest of the oral cavity, the palate, buccomucosa, floor of the mouth, tonsillar fossa are normal. On palpation, an ulceroproliferative lesion over the left lateral border of anterior two-thirds of tongue measuring about 3 into 2 centimeter. It bleeds on handling. Firm in consistency with uneven surface. Irregular margin with surrounding induration extending about 0.5 centimeter around the ulcer. There is no extension to the floor of the mouth or jaw. No lesion palpable over the cheek, buccomucosa, retromolar trigone, or posterior one-third tongue. This is a clinical picture patient. The induration actually crosses the midline at the tip, sir. Examination of the neck. Palpated from behind the patient with neck in flight flexion. There is no cervical lymphadenopathy present. Examination of the cranial nerves 9, 10, and 12 are normal. Examination of cardiovascular system, respiratory system, abdomen, skull, and spine were found to be within normal limits. Summary: a 56-year-old lady who is a tobacco abuser with no known comorbidities, presenting with ulceration of the left lateral aspect of tongue, past 2 months duration. A 3 into 2 centimeter ulceroproliferative lesion, the left lateral aspect of tongue with irregular margin, which bleeds on touch with surrounding induration with no palpable cervical nodes. My diagnosis would be carcinoma anterior two-third tongue, left lateral border, clinical stage of T2, N0, M0, that is stage 2.
Okay.
Can we go back to the slides?
Yes, sir, please. Yeah.
Yeah. Well, is it involving the tip of the tongue or?
Sir,
You said initially it is 1 centimeter from the tip of the tongue, and the palpation you told it's involving the tip and crossing the midline.
yes, so the induration is actually crossing the midline, sir.
But
Okay.
even the tip of the it has crossed the tip of the tongue. When you compare to the opposite side, the growth has extended up to the cross the tip of the tongue. See.
Yes, involving the tip of the tongue.
Yes, so the induration is involving the tip of the tongue, sir. It has almost crossed the tip of the tongue, sir.
Okay.
Yeah, but how do you describe it on inspection?
Inspection itself it has crossed.
So in inspection, I would say there's a surrounding edema which has crossed the midline at the tip of the tongue.
Again, Kapil, I think this is a very, very tricky question. When you are describing the ulcer, probably you are describing only the posterior part. But see, that is trying to be very, very specific only for the ulcer. But you can see a lesion. It's an ulcer along with the swelling, irregular swelling, which is crossing the tip of the tongue. So you when you are describing the whole lesion, and it is not just like an ulcer which you draw in a diagram. So it's a little very irregular kind of disease. So it is definitely difficult to put it in words. But as you can see, you cannot miss it out that it is not involving the tip of the tongue. It is definitely seems to be involving the tip of the tongue.
Your finding of 3 into 2 centimeter, is it a palpatory finding or?
Yes, sir, palpatory finding.
It's only 3 into 2 centimeters.
Yes, sir.
Kapil,
Sir?
look carefully the right, tongue border, that anterior, so-called the lateral border, and the left. Dr. Sharad sir is telling you see the irregularity and look at that border. So you should have probably described the whole lesion, I think, from the tip as a whole. That's what I feel so.
And it appears a little bigger than what you have described.
Yes.
It has a proliferative component which may be 3 into 2 centimeter, but the indurative component is crossing the midline and much bigger.
Yes, sir.
Okay. How is the floor of mouth? Is it involved?
So not involved, sir. Tongue movements are also fine, sir.
How far it is from the alveolus, floor of mouth? How much normal mucosa is there between the disease margin and the alveolar margin?
So around 1 centimeter, sir. The patient is able to lift the tongue upwards and
okay.
breathe, sir.
Okay. How is the dentition? So any oral cavity examination, you should mention first thing as dentition, then the oral hygiene.
Okay, sir.
Those things you have to mention.
They should give us the dental formula also. Whether there is any
sharp teeth or any missing teeth, or those things you have to mention with importance.
Okay, madam. Yes.
So
and you can revise your size, everything, because this is across the midline. From the midline, now you have to measure your size. That will be the exact size of the measurement, because your staging is going to change, no?
Yes, madam. Kapil, what madam is telling is by inspection itself, you see, you are able to see the swelling. It's not a palpatory finding. On inspection, we are able to see the swelling here.
Yes, sir.
So the swelling should occur here. If this alone is normal and you palpate it by induration, you can leave it. So this as I said, you should be very specific in your presenting. Okay, Shanai sir, please.
Kapil, that's what just now Srinivasan sir has clarified. Look at that lesion again and again. See how irregular it is on even in inspection. Okay, so
yes,
sometimes it is a little nicely round. Sometimes it happens in some kind of a other lesion. You might not have seen the what you can call as a Sippel syndrome. You heard of Sippel syndrome? multiple endocrine neoplasia.
Yes.
So mucocutaneous neuromas, I have seen 2 cases, or some other lesion in the tongue, but this is very irregular. So when you describe on inspection itself, probably you can start from the inspection from the tip of the tongue itself, the lesion.
Okay,
The only thing is what we are seeing on the tip on the side, it may not be ulcerated, but distal to it, there is an ulcerated swelling. On palpation, obviously induration is extending. That's what you have told up to the tip. What are the common areas where you can miss sometimes the ulcers or a growth in the oral cavity?
Sir, the areas where we can miss is the posterior 1/3 of tongue, vallicula. And,
vallicula and all, it may be difficult.
Those areas are actually not this oropharyngeal areas, not the typical oral cavity.
We are asking you in this oral cavity, in the examination of the oral cavity in general, some areas you may tend to miss if you do a cursory examination. So carefully you should retromolar trichome and posterior one. How do you examine the posterior 1/3 of the tongue?
Sir, with the tongue depressor, tried examining the patient, sir. But ideally, I have to do laryngoscopy, indirect laryngoscopy.
So that is later. We are now clinical examination. You are a surgery PG. This patient has come to OPD.
Yes, sir.
Okay. Now I want you to mention how did you examine for the oral cavity? Sorry, posterior 1/3 of the tongue. What I want is it's a palpation finding, not inspection finding. Clear?
Okay, sir.
So you have to carefully palpate for what? Palpate for what?
Any irregularity.
Irregularity and induration. Sometimes you get a induration. What is frozen tongue? Heard of entity? Frozen, like a frozen fish. You know what is frozen tongue?
It's an advanced disease, diffuse infiltration.
Whole tongue can be, sometimes converted to a small mass of a hard indurated lesions. So you should look for.
Why? What is ankylosing?
So it's tongue ties the frenulum portion or the ventral portion of the tongue gets adherent to the floor of the mouth.
No. Ankylosing means there is a patient is unable to protrude the tongue.
Protrude the tongue.
Okay.
So what is the reason for ankylosing?
Cancer, it may be due to infiltration in the floor of the mouth, sir.
Not only floor of mouth, it's mainly because the extrinsic muscles of tongue infiltration, the genioglossus, hyoglossus.
Palatoglossus.
When the extrinsic muscles are infiltrated, patient is unable to protrude the tongue. That is called ankylosing. In patients with submucous fibrosis, even without, they will have ankylosing because of the fibrosis of the tongue.
Yes, sir.
Okay, these are the causes of ankylosing in relation with malignancy.
Okay, sir.
Okay.
This is the history what was needed in the history itself. At the moment of the patient is able to have the same movement before shear. Movement of the tongue is normal.
Yes, sir.
If you ask the history whether the movement is normal, then you'll ask about the history of ankylosing. Because when the muscles are being infiltrated, the movement of the tongue will be affected.
Okay, madam.
Appeal.
Sir.
Such an advanced lesion, why the patient does not have trismus in your patient?
He has got trismus, sir. The way the patient opens the mouth, it looks he has got trismus. Mild trismus.
All right. She is able to protrude. I agree, but what are the? Okay, I'll put it other way. What are the reasons for trismus in a oral carcinoma in general?
Sir, in case of advanced lesion, when the pterygoids are involved, when the
So when do you get the pterygoid infiltration?
Is it common in carcinoma tongue? Trismus. Ankylosing is common, but trismus. Yes. What about trismus?
Is it common?
It is not common in CA tongue, sir.
Tongue lesions. Okay, it's basically in the RMT lesions where the disease deeply infiltrates into the pterygoid muscles very easily.
Yes.
Any other reason for trismus in general? Look at some of the pre-malignant condition. You may get the answer.
Fibrosis.
So you can any other reason for trismus. Suppose you see radiation marks in this patient. Say patient is taking radiation. What is the cause for trismus?
Radiation stomatitis, sir.
Stomatitis. Stomatitis.
Stomatitis is a very acute problem.
Actually, osteonecrosis of jaw. Or...
No, don't go to necrosis and all right now. They may radiation, people may get angry with you that they are poor radiation. Don't say that. Just say soft tissue fibrosis. You know, radiation can cause soft tissue fibrosis.
Okay, sir.
That's a late sequelae to radiotherapy.
Okay, sir.
Okay.
So the pterygoid muscle, is it both the pterygoid, sir, or the lateral pterygoid alone, sir?
Usually trespass is mainly because of the pterygoids infiltration, mainly the lateral pterygoid infiltration. Any muscle of infiltration of any muscles of mastication can lead to trespass. Masseter, medial pterygoid, lateral pterygoid, but mainly it's a lateral pterygoid involvement that causes, or any fibrotic band in that area, SMF, or can cause, or so any severe infiltrating ulcer causing pain can also leading cause of trespass.
Kapil, do you think the posterior third of the tongue involving the floor of the mouth can cause trismus? So, very near the mandible.
Not trismus, sir. Patient will present with difficulties following recurrent respiratory tract infection, sir.
But, don't you think it will involve the medial pterygoid over there?
Chances are there. Retropolar, yes.
Yes, sir. The disease getting advanced, it can involve the muscles.
Yeah, sometimes actually, sometimes even the tongue lesions can also cause trismus by the involvement of the medial pterygoid, especially situated posteriorly.
What is the usual normal mouth opening? How much?
Sir, 3 finger breadth, sir, or more than 3 centimeters considered adequate, sir.
Not 3 centimeters. 3 finger. Usually 4 to 6 centimeters. That is the usual. Around 5 centimeters.
Okay,
anything
sir.
less than 4 is considered as. Between 3 and 4 is grade 1. Between 2 and 3 is grade 2. Anything less than 2 centimeters is considered as severe trespass or a grade 3 trespass. Okay.
Don't say fingers, Kapil. Whose fingers?
Roughly.
Your small boy, his finger will go. This is the patient fingers. So, as sir said, you tell it in centimeters.
Centimeters, yes, sir.
Yes, okay.
Sir, one or two simple anatomic question.
Please, sir.
What are the muscles you have tested, Kapil, for the tongue movements?
Sir, protrusion of the tongue.
What muscle causes that?
Genioglossus, sir.
Any other? Yeah, please tell the other tests which you have done. If you are done, say. Otherwise, say no. I can make out by looking at you.
What is the muscle which touches the palate?
What is the protrusion alone, sir? That's
correct. I know. That's why I asked. That doesn't matter. It's an important one which are tested. So just to know the theory, at least, what causes elevation? Touching your hard palate. Touch your hard palate. You know which muscle does that. It should be simple.
Palatoglossus.
Palate to tongue. Yes.
Remember palate.
What muscle causes a backward protrusion? There's some process, styloid process behind. So,
given the answer.
And what muscle causes a depression? You have got hyoid bone here, no? Down. So, it's a simple thing. Okay. Examiners will ask you so that you should not be in trouble in the examination. That's why I'm asking you. So you should know extrinsic muscles and intrinsic muscles. What is the function of intrinsic muscle? Simple question. Intrinsic, within. That without that we can't chew. You can't clean your oral cavity. You can't touch the hard palate. All altering the shape. That one word is enough. Okay, shape of the tongue. Tongue. Is it clear? All longitudinal, circular, all those muscles are there. So just simple word. Altering the shape of the tongue. That's enough. Okay. Right, sir. Mike, for the side overs.
So your examination is complete.
Yes, sir.
I just wanted to ask you one more question, Kapil.
Please, sir.
You said the tongue is not, showing any deviation. When does the tongue begin to show any deviation to one side, and why?
Sir, if there is infiltration of the hypoglossal nerve, there can be deviation to the affected side.
Affected side. Okay.
Affected or opposite?
Where does the tongue, I mean the tip of the tongue point, or the which side does it move?
Sir, if the left side hypoglossal nerve is affected, the tongue will deviate towards the left side, sir. The tip will deviate towards the left side, sir.
And why would it do
Yes,
so?
especially
if the tongue muscles are paralyzed, the other side would contract. So
Yes,
won't it go to the opposite side?
No, sir. There will be actually a decussation of fibers, muscle fibers. So
the unopposed action of the opposite muscles push the muscle to the paralyzed side.
yes, sir.
Oh, okay. So, do you think
Okay.
examination of endoscopic examination of the upper aortic tract
Yes,
is
sir.
important?
He said the examination of 3 cranial nerves. Why that's
Okay.
important, sir? Tell
Which one?
Yes, go to the slide. Sir, he said examination of cranial nerve 9, 10, and
9, 10, and
12.
12.
It's mainly you will check for the hypoglossal nerve, glossopharyngeal, and
yes.
Other is the sensory only, sensory loss or taste loss. Usually, mainly you check for the hypoglossal and tongue
That is
lesions.
12th. For 10th, how did you do that?
I just tested the sensation of the posterior pharyngeal wall and checked whether there is gag reflex or not.
For anterior two-third, which is the nerve that is for sensation.
It's a lingual nerve, madam.
Posterior one.
Glossopharyngeal nerve.
Okay.
Okay. What do you mean by synchronous primary?
Sir, the patient comes with a particular lesion in the oral cavity, and within 6 month duration, that develops another lesion. It's considered to be a synchronous lesion.
Okay. What is the possibility in oral cancers?
Synchronous lesions are, there's an incidence of around 30% of synchronous lesion in oral cavity malignancies.
30%. That is little too much. Maybe around 5 to 10%. Especially in patients with tobacco habits, there is a high chance for other lesion, especially those of diffuse changes or field cancerization changes in the oral cavity. Always you check for a synchronous primary in the posterior oropharynx or other areas.
Yes, sir.
So your examination is not complete except without an indirect laryngoscopy or endoscopy of the posterior oral cavity. Okay. For completion's sake, I'm telling.
Okay.
Phil, what do you understand by field cancerization?
Synchronous and metachronous lesion because of this tobacco being affecting all areas of the oral cavity.
Yes,
Khanna sir, please. Or can we go for the investigation and management?
What do you understand by field cancerization?
Okay.
The patient is when a patient abuses tobacco, the entire aerodigestive tract, starting from the oral cavity to the lungs and the esophagus, is exposed to these toxins. So the patient can develop lesions anywhere in this region, sir. It is called field cancerization.
Good.
Can you tell what is the difference in the location of the lesion in a HPV related and non-HPV related?
The HPV related can occur in the tip of the tongue or the lips.
HPV related tip of tongue. No, HPV is basically related to oropharyngeal cancers.
So they are posterior cancers, no? Non-HPV are the anterior one. HPV related are mostly the posterior cancers. The posterior third of tongue may be there. Pharynx may be there.
Basically, it's a invested population. About 2/3 of the oropharyngeal lesions are HPV related, mainly in the tonsillar fossa or the valvular area. But in our population, the incidence of HPV is very low, especially in a patient like tobacco habits. It's mainly non-HPV cancers, old age patients. HPV related cancers are usually in young patients without habits, usually with large nodes, cystic nodes, they usually present. Oral cavity is very less association with HPV. Okay.
Okay, sir.
Which HPV?
Madam, HPV 16 and 18 groups, madam.
But oral cavity 16 is more common.
Okay, madam.
Karna sir was asking question.
Is there any correlation between the squamous cell carcinoma of the oral cavity and the squamous cell carcinoma of the cervix in a couple?
Sir, if it is HPV related, there can be some correlation, sir.
Yeah, people always thought that probably there will be correlation will be there, but there are several studies which has come that probably there is no correlation between somebody having the carcinoma of the cervix and somebody having the carcinoma of the oral cavity. It was thought probably it's a common pathology which is there, so it should be there. But many of the studies which has come, they say probably there is not much of the high incidence is there.
Okay, sir.
Okay.
Okay, I think Kapil, we can move on to the investigation. How do you manage this patient?
So I'll do investigation to confirm my disease, to stage the disease,
Okay.
and the management part.
Okay. How do you confirm your diagnosis?
Yeah, I'll take a HH biopsy from the lesion along with a bit of normal tissue. And,
What biopsy? Incision biopsy? Punch biopsy? What do you take?
I'll take biopsy from the edge of the lesion, sir.
Okay.
Edge of the ulceroproliferate along with some bits of normal tissue I'll be taking, sir.
Okay.
What do you call that as? HH biopsy?
HH biopsy, madam.
Why would you prefer the edge? Why not in the center of the lesion?
The edge has actively proliferating cells where the central portion there can be of necrotic tissue which can misguide us.
Okay.
Would you like to give anesthesia to take the biopsy?
Not necessary, sir, but patient is very anxious. I can infiltrate locally, sir.
Okay, so basically we don't give locally with the fear of trying to spread of the malignant cells. So local anesthesia is usually avoided. Small biopsies, most of our patients tolerate well, and so we take punch biopsies most of the time without any anesthesia.
Okay, sir.
Can I ask a question, Kapil?
Yes, sir. Please, sir.
Since you told anesthesia, that means so you are prompting the examiners in oral cavity, which type of patients you may have to subject them for anesthesia under GA and take the biopsy.
Sir, when you are doing a triple endoscopy or pan endoscopy?
Not okay. What answer I wanted was your 1 or 2 biopsies failed, posterior 1/3 of the tongue, difficult cases. There may be a chance of a bleeding, aspiration, patient is not cooperative, advanced lesion, they are stuck to the posterior pillar of the tonsil, etc. There are 2 ways. One, you can take a biopsy and you can assess also. No doubt you will do a scans later, but clinical plus assessment of the lesions. When in difficult cases, don't try to put the knife or a blade inside for a posterior 1/3. If patient bites, means you will have a major problem. So
Yes,
if
sir.
there is a lesion in the posterior 1/3 of the tongue, if you are asked to take a biopsy, what instrument you will use for take a biopsy?
Under anesthesia, sir?
No. In the OPD, let us say. There is a lesion. Okay, I will give a clue. Post-proliferative. It's like exophytic one. Cauliflower-like thing is there. So what instrument you will use? You will use the knife? Blade
No, sir.
like this?
I'll just use my Alice forceps to just...
That's a tip.
It may cause bleeding.
Sir is very specific. See, proliferative growth age from where you take the biopsy. So
just
will
now
you use
mentioned some punch biopsy, no? What is the name?
So you have a punch biopsy forceps. Usually most of the areas don't have to do an incision.
So these are simple things, Kapil, you need to know. Incision biopsy is very, very simple, corrector, but you should know it should be accessible area. You should be able to control that. Punch biopsy is for a deep lesions. Carcinoma of the cervix. How do you take a biopsy if the question is asked? Like that only, it's a punch. So because it's a long instrument, having a long blade. Have you seen a punch biopsy forceps?
Yes, sir.
You have seen. Then why you didn't answer? So you need to take biopsy. Clear. So incision biopsy, edge or a wedge biopsy, punch biopsy, all these are standard questions and assessment in the theater. Okay, sir.
Yes, sir.
Sir, is there any role of excision biopsy, sir? Desai sir or Shaji sir?
Yeah, I think Kapil should answer this question.
Such a
Kapil.
large.
Sir, Kapil, let him answer. I thought, yes, Kapil. Is there a role for excision biopsy?
Sir, no,
Not in this case, in any other case.
Yes, madam. Yes, madam.
the lesion is very tiny.
Tiny
And
means
less than 2
0.001 millimeter.
less than 2 centimeter lesion.
Yes, sir,
No,
please,
clinically detected.
Desai sir, you can.
So any excision for this patient will need anesthesia. So don't attempt for an excision biopsy. You
Not in this patient, sir.
get the tissue diagnosis, then go for a planned surgery.
Not in
For a
this
very,
case.
very,
See,
very
Kapil,
marked lesions or a small lesion.
Small lesions.
Yeah,
And,
lesions which are less than 4 millimeters, 3 millimeters, you can consider excision biopsy. But that when they're very small and when they're probably benign. But let me tell you one thing. The
oral
tongue
is a mobile structure.
Yeah, tongue is a very mobile structure. It's a very precious organ. Very precious organ. In the sense, even if you want to lose small amount of tissue, you have to be very careful. And nobody would want to lose a small amount of tissue, especially if it's a benign lesion. So in benign lesions, you don't really have to excise anything. And so in malignant lesions, you have to do a wide excision. So the role of excision biopsy does not come really have a place in any of the biopsies. Which
moreover, it's very
lesions.
difficult to get a
Margins.
Margins. Very difficult because patient will be constantly moving the tongue, very anxious. You won't get a proper margin. So it is better not to attempt for a excision biopsy under local anesthesia, except for a very, very small lesion. Yes. What is the histology you expect to get this patient?
Most common is squamous cell carcinoma, sir.
Okay.
Any
other? What percentage of oral cancers are squamous cell carcinomas?
So more than 80%. Sir.
What are the remaining?
There can be adenocarcinoma, sir.
Adenocarcinoma. Usually salivary gland origin. Then usually more than 95% is squamous cell carcinoma. Okay. What else you want to know? What do you want to know? The grade, well differentiated, moderately differentiated?
Yes, sir. Depending upon the grade, it will be useful for me to plan the treatment, whether to go in for new adjuvant or post-adjuvant, post-surgery adjuvant radiation to be given or not. Depends upon the grading, sir.
Those you will get the final histology.
Yes, sir.
Okay.
No, but
yes,
you don't plan your adjuvant therapy according to the grade. Grade, you know.
No.
I mean, just because you get a grade, which grade will you do what adjuvant therapy?
Sir,
there is no definite recommendation based on grade of the disease. Only thing, poorly differentiated has a more chance for local regional recurrence. That is the only thing. Based on grade alone, you don't plan your adjuvant treatments. Okay. Previously, there was a recommendation for addressing the neck in clinically ensure neck. If it's poorly differentiated, there is more chance for nodal metastasis, and you have to address the neck, but not like that. Okay.
What is the investigation you'll do to look for the nodal? You told clinically there's no node palpation.
Yes,
there's
madam.
no beam present. But do you want to confirm it or not?
Yeah,
I'll
go in for the ultrasonography of neck.
So you did a biopsy, then you want to do ultrasound. Ultrasound of
neck. Yes, sir.
For what?
pick up any nodes, cervical nodes.
Okay. So if there is a suspicious, there is a 1 into 1 centimeter suspicious node in the level 2.
Okay, sir.
Will you
Kapil,
go
would you
for
want
an?
to image the tongue?
Sorry, sir.
Would you want to have an imaging of the tongue lesion?
Sorry, sir.
Primary lesion. Will you do a cross-sectional imaging, CT or MRI for the tongue? Is it useful for this patient?
If clinically, I mean, actually it is crossing the midline, sir. So to check for the floor of the mouth involvement, I will do an MRI of tongue, sir.
MRI, what additional information you get?
It gives a
tongue or MRI of the oral cavity and neck.
oral cavity and neck, madam.
Apart from that, your posterior limitation.
So then why do you want to have ultrasound again?
Sir, here clinically, there's no, the induration is not extending to the floor, sir. So I just did an ultrasound alone.
See,
the will not be clear with your. It will be better with your MRI.
Basically, Kapil, this is an examination. It is not actual practice. So in an examination, you have to put it as theoretical as you can. So routinely, I also know that I would not do a MRI most of the time. But in examination, so if you would say that you would, if the patient can afford, and if you have got the facilities, that you would do an MRI of the tongue and the neck, which also gets the MRI of the neck also. So that would be the most standard way of presenting. And if you don't have a facilities, or if the patient is economically compromised, then you can go.
Sir, one question not to you, sir, but just to, I think between CT and MRI, candidate should tell MRI, no, MRI of the tongue, correct?
Definitely for soft tissue, MRI is better. Yes. Intrinsic muscle infiltration.
And especially if you want to take a decision of hemi or versus, so is it that the one reason? Hemiglossectomy or a partial glossectomy, is that the one reason?
See, most of the time, imaging helps us in doing the surgery, but the surgery is finally done intraoperatively depending on the inspectory and the palpatory findings.
Yes.
Okay, this patient has a clinically infiltrative disease crossing midline more than the actual seen disease. So there will be pseudopodial extensions into the muscles. So MRI may give a better picture about the infiltration of the disease. So MRI, if the patient can afford, MRI may be considered.
Okay, sir.
Okay. Kapil, so, if you suspect the bone, especially mandible, what is the better investigation?
Then I will do a CT scan, sir.
Did you examine this patient for mandible infiltration?
Yes, sir.
Did you mention?
I didn't mention specifically mandible, sir. I just
he told it's away from the mandible. Its floor of mouth is not involved.
But better no. Whatever said and done, oral cavity means you should make a habit. Even though it is away, we all know. But better to mention bidigital examination. There's no periosteal. There is no thickening or tenderness. So that you say no. Okay, that's enough.
Okay, sir.
Can we proceed to the treatment part, sir?
Yes, definitely. Yes. So you did biopsy. You did a cross-sectional imaging. Then further, how will you proceed? What is your treatment plan
for this patient?
For this patient.
For this patient, actually, the lesion is crossing the midline. So I'll give a 1 to 1.5 centimeter marginal clearance and do an elective neck node dissection.
1.5 centimeters.
Kapil.
So how can it be?
So 1.5 centimeters all around laterally, you have to take the mandible. It is just
tongue.
Kapil, one important observation, and you should discuss this point. Whenever you remove somebody's tongue, whether it's a partial or hemiglossectomy, what
Yes,
is
sir.
the major disability this patient can get?
Difficulty in speech, sir.
Speech and
Swallowing difficulty and mastication.
Don't you think that if there is any alternative, you will consider first? This is how you should, I think, start with the preservation of the organ. If it is not possible, then you go ahead with the surgery, right? You
Okay,
have
sir.
any other options? What is the indication for surgery and radiotherapy?
The patient is, she's not a fit patient or very old age, unfit for surgery, not willing for surgery. We can go in for external beam radiation, sir.
so there is no doubt for a oral tongue, surgery is the mainstay of treatment. Except for a very small lesions away from the mandible, you may use interstitial implantation in the previous days. So otherwise, usually surgery is the first line of management in tongue lesions. Buccal mucus and all, you have a radiotherapy, also an option. But for a oral tongue, especially this much of thick lesion, surgery is the mainstay of treatment.
Okay, sir.
What do you mean by the tumor thickness and the depth of infiltration?
Sir, depth of infiltration is included in the latest AJCC edition, sir.
Okay. Latest means which edition is
Eighth
latest?
edition. Eighth
Eighth
edition.
edition. Oh, okay. What are the changes that they have incorporated? New things incorporated.
So if the depth of invasion is less than 5 millimeters, it comes under T1, sir. If it is between 5 to 10 mm, it comes under T2 lesions.
Okay.
And if it is beyond 10 mm, it is T3 lesions.
So what is the difference between DOI and tumor thickness? Depth of infiltration and tumor thickness.
Depth of invasion is from the basement membrane of the tumor epithelium to the structures below. That
Not
is
the tumor epithelium. It is from the normal basal layer to the deepest layer of the tumor. That is the depth of infiltration.
Yes, sir.
Tumor thickness is from the surface of the tumor
Yes, sir.
to the deepest layer.
Which of these is more important?
Definitely, depth of invasion is more important.
Why?
Sir, it decides prognosis of the tumor. The grade, the staging also is altered, sir.
Mainly because it is infiltrating into the tissue substance. When it infiltrates deep into the tissue, it is likely to involve the vessels, perivascular involvement, lymphovascular involvement, and the perineural involvement. So there is a high chance for nodal metastasis and locoregional recurrence.
Okay, sir.
That is why depth of infiltration is more important than the tumor thickness.
Yes, sir.
Okay. So you told 1.5 centimeter margin. From where you got?
Sir, 1 to 1.5 centimeters.
Usually, what you
that's okay.
Okay. What is adequate is.
So, but when the tumor is so more than 2 centimeter and it crossed the midline, this 1 centimeter margin, will it be possible for this patient?
Here, it is not possible, madam. So can go in
for this patient can be done.
Hemiglossectomy.
So, what additional precaution you take to make your margin negative? Any additional step?
The induration portion, I have to give clearance to the induration also.
Definitely. So usually what is advised in oral cavity is minimum of 5 millimeters. Anything less than 5 millimeters is considered as close margin. So anything more than is adequate margin. Because tongue is a very vital organ. Too much loss of muscles will cause functional mobility. So you have to balance the clearance at the same time, retain the function.
Okay.
So any additional precaution I ask? Frozen section. What is frozen section?
Intraoperatively, to decide the margin after resection of the tumor from the free edge, I'll take tissue for frozen section.
You excise the tumor and unfixed tumor, you send for a assessment of margins.
Yes,
Okay. If any close margin, you have to re-excise. Okay.
Yes.
Okay. Then how will you address the neck? Will you
Is
address?
it that you take a separate?
Please, sir,
Do you
yes,
take
yes,
a
sir, please.
separate biopsy from the tongue after resection, or do you send the specimen itself for the frozen section?
Sir, the specimen is adequate, sir. From the specimen, we see the margin.
Okay, there have been there are different institutions can practice differently. So basically, some institutions prefer to send only the specimen and get the specimen studied, while there are some people who try to get separate biopsies from the bed of the resection and send it for frozen section. Anyway, generally it is believed that if you send the specimen itself, which is the commonest practice, and that is quite adequate, and that is a better practice.
So before you sending the frozen, you have to tag the margins: the anterior margin, posterior margin, lateral margin, and the medial margin. All margins has to be tagged separately and sent for frozen, so that the pathologist, or you have to ink the margins.
Okay, sir.
Okay.
Neck, how will you address?
Sir,
Clinically, it is N0. So what is selective neck dissection? What is therapeutic neck dissection?
if, clinically and imaging wise, there is no cervical lymph nodes, but still we go in for neck dissection. We call it as selective neck dissection, sir.
Okay.
Now tell this lady is a very uneducated lady. You are going to tell her that she knows that she doesn't have any swelling in the neck, no problem in the neck. Now you have to tell her that you are going to operate on the neck. How
Yes,
would
sir.
you like to explain, and how would you ratify your decision?
So I would say that the lesion is crossing the midline, and so there is a probability of involvement of the neck nodes, and if it is untreated, the lifespan of the patient will be reduced. So it is better to go in for neck dissection. I will explain the patient.
So this patient has a thick T2 lesion, which is crossing midline. What is the chance of occurred lymph node in this patient?
Sir, 25%, sir.
No, not 25. It's almost something like a 40%. Because it's a thick T2 lesion crossing midline. So invariably, you have to address the neck. That is,
Okay.
there is no recommendation for observing neck for such a thick lesion. Okay.
Okay, sir.
So you have to address the neck. What form of neck dissection you do?
Sir, suprahomoid, extended suprahomoid neck dissection, sir.
What do you mean by extended suprahomoid?
Removal of level 1, 2, 3, and level 4 lymph nodes also, sir.
Okay, what is the logic or rationale in doing a suprahomoid neck dissection?
Sir, the peculiarity of tongue carcinoma is that they are prone for skip lesions, sir. So directly they can involve level 4 without involvement of level 3 or level 2, sir. So it's better to do level 4 also, remove the level 4 nodes also, sir. Sometimes they can involve directly to level 5 also, sir.
So you want to clear level 5 also?
But
what is the chance? What is the chance of level 5 lymph node involvement when you have clinically N0 neck?
I don't know the exact.
Usually it is very less. Let's in the tune of less than 5%, 3 or 4%.
Less than 5%.
5. So you don't have to routinely go for a level 5 clearance. You can spare. Why are you so concerned about level 5 clearance? What is the morbidity in clearing level 5?
Sir, there can be injury to the nerves.
What nerves? So if you clear the level 5, there is a chance for an inadvertent damage to the accessory nerve, which causes shoulder drooping and shoulder dysfunction. So even if you preserve the nerve, with the traction on the nerve can cause praxia. So many evidences have shown that if there is not much lymph nodes, you can spare the level 5. Okay.
Okay, sir.
Kapil, would you send the nodes for frozen section since you already have a frozen section?
Sir, actually, we don't send in our institution. We just do elective. We do suprahomoid neck dissection and send the specimen for histopathological. We don't do frozen section. It can be done, sir.
No, not can be done. See, basically, again, you are in an examination. You try to give the best possible scenario to the examiner. So in this situation, when you have got the facilities, then, so when you remove the nodes, send them for frozen section. If multiple nodes or if nodes are involved, there is naturally a tendency that you will have to do a extended dissection. Maybe you will have to convert your neck dissection into a complete total R&D. In the sense, modified radical neck dissection, especially clinical negative dissection. Because nodes, you see, basically, whatever you have evaluated before is with your hand and or if you have done a MRI. But then there can be small lymph nodes which are very small, be evaluated by also, which can come positive. And if the nodes are positive, it is preferable that you can do a completion modified radical neck dissection.
Okay, sir.
Kapil, will you address the opposite neck? It's involving the crossing the midline and involving the opposite neck.
Yes, sir. In this patient, I'll do contralateral neck dissection also, sir, because it is crossing the midline.
If you do both the side neck dissection, the same sitting, what do you anticipate? Complications? What precautions to be taken?
Since it is only a suprahomoid neck dissection, there
The complication rate is less.
Yes, madam.
Okay, you did a wide local excision. So how will you close it? The tongue defect.
I close it with the flap cover, sir.
What flap you use?
Radial artery forearm flap is commonly used.
Radial artery flap. Okay. What is the age of the patient? 62.
56, sir.
56. Okay. Do you think she will tolerate such extended surgery?
No, sir. Difficult in this patient, sir.
So what do you, is there any alternate options?
Sir, I'll just do split skin grafting, primary closure and split skin grafting.
Primary closure. If you can cross primarily, there is no need for graft. And skin grafting in tongue is not a ideal option because tongue is a mobile structure. It's keep on moving, and the graft take is also may not be good. And the long term also the graft will contract and the tongue will become very fibrous. So what other local flaps you can consider for this patient?
Deltopectoral.
Deltopectoral.
Oh no.
That's too much. Or okay,
look at the lady.
MS level. Okay, you can.
You can answer Saji, sir.
There's options like nasolabial flap, or even some is a submental flap or something. Nasolabial flap usually we use, or even there is something called a facial artery mucomuscular flap, FAM flap or something. There's a lot of options for local flaps in old patients who may not tolerate for a lengthy microvascular surgery. There's options.
Okay, sir.
So I think in this lady, you would just exercise it and try to do some amount of closure, or you can even leave it open, but do a proper suprahomoid neck dissection and then finish it off. You don't want to extend the surgery for this old lady.
Yes, sir.
What are the expected complications after this surgery?
Sir, following neck dissection, there can be injury to hypoglossal nerve, lingual nerve, sometimes phrenic nerve, and
Kapil, see, let's say even though MS examination, even in MS examination, when you say when I ask, this is a common question, stock question of the examiners. When somebody says complications, you should say complications intra-op, immediate post-op, and delayed post. These are the common. And then, of course, delayed complications which can occur over the period of months and years. So this is how you should classify, and you should say at least 3 to 4 of them immediately.
Yes, sir. Intraoperatively, there can be damage to neurovascular structures. There can be hemorrhage.
Bleeding.
Yes, sir. Post-operative, immediate post-op period, there can be hematoma formation. There can be injury to marginal mandibular nerve, and the patient can have a drooping of one side of angle of mouth. There can be serum formation.
What is skyleak?
Sir, sometimes when we remove the level 4 nodes, there can be injury to thoracic duct. So that can lead to chyle leak, sir.
Is it possible for this patient?
So here we are going to do suprahomoyoid, sir. So
You told extended suprahomoyoid. You are clearing level 4 also.
yes, sir. That can be
And
possible.
looking on the side of the lesion. Which side is this?
Sir, left side, sir.
Left side. Is it more prone for a thoracic duct injury?
Yes, sir. Definitely, sir.
Okay. Okay. Chyle leak is is a complication of neck dissection.
Yes, sir.
Sometimes you may not identify the injury intraoperatively. If you see it, you can suture ligate or transfix it or something. Sometimes you may not identify it.
Okay, sir.
Okay, only thing it manifests in the post-operative increased drainage and with milky color. Okay.
Yes, sir.
Oh.
So I think we should close the session.
You can go for the next case, sir, please.
Thank you, sir. Thank you. Kanna sir, you want to give your closing comments before going to the next one? I think we lost. Kanna sir?
Yes, sir. Yeah. Hello.
Yes, sir. Yes, sir.
Can you listen me?
Yes, sir. Very well, sir.
Okay. Okay. I think, oral cancers will be always there in the exam as a short case. So you should be always ready with the oral cancers. And most of the time you will be asked about that what are the various pre-malignant conditions which are there, what are the types of the biopsies which will be there, how will you confirm your diagnosis, and then what investigations you are going to do. Probably for the tongue, you will definitely do the MRI for these patients. But if you really want to see for the lymph nodes and the bone, then you will go for the CT scan of that. And if it is like this patient is the N0 node which is there, but even in the N0 neck which is there, almost about 20 to 30% possibility of the positive nodes are there, which can be detected by the CT scan. And whenever there is a cancer, the tongue is there, it's taken as a relatively aggressive cancer as compared to the other cancer which are there. So cancer of the tongue and the floor of the mouth which are there, these are the two places in the oral cavity which to be taken as aggressive cancer as compared to the other cancers. And in all these patients which are there, you have to carry out some type of the block dissection has to be done. It may be a functional block dissection which you may carry out, but it has to be carried out in almost all. While in the case of the cheek cancers or in the lip cancers, you can just simply do like a supraomohyoid type of the dissection can be done. But in these cases, you have to go for the formal neck dissection, which may be modified neck type dissection rather than having a radical type of the neck dissection. Thank you.
Yes,
Thank you, sir. Thank you. Dr. Kapil, is a normal custom for this group. Do you have any questions to the faculty? Any doubts to be clarified with the senior faculty here?
No, sir.
Thank you, Dr. Kapil. I think credits to you. Yes, sir. Shaji, sir, please.
Kapil, you did well. In spite of that, you being an MSPG, you did well.
Thank you, sir.
Okay. A very good presentation.
Thank
and
you.
I'm for everything.
Thank you, madam. Thank you, Shaji sir. Thank you, Kapil, for staying with us. I think credits to your chief, Professor Srinivasan sir, for getting ready for this presentation also. Thank you so much. Now, I think I could see one senior doctor, Dr. R.S. Agarwala sir. Sir, good evening, sir. Can you identify, sir? It looks like you are a senior person. Just want to introduce yourself, sir. Please unmute yourself, sir. Sir, please unmute yourself, sir. So in the meantime, Dr. Zarin, you can get ready with your presentation. Let Dr. Agarwala sir get introduced. It looks like he's a senior man. We'll be happy to formally introduce him.
Left lower corner, Dr. Agarwala, left lower corner.
He is fine. Good evening, sir. No, not able to hear us. Zarin, what type of system you are using, ma? You are coming from your phone or from a system, Dr. Zarin?
Sir, laptop, sir.
Very good, very good. You are ready with the presentation?
Yes, sir.
Okay, one moment. Agarwala sir, I think we will go to the presentation. We will get introduced soon. He has some challenges.
His request is son or somebody is there to put
They're trying to help.
introduction in the chat box for the
Okay,
time.
sir. Okay, sir. Okay, no problem. Thank you, sir. Thank you. We'll go on to the case. Dr. Zarin, please share your screen. Please introduce your chief and then start your presentation. Zarin, unmute yourself, Zarin. Yeah.
Hello? Yes,
Please
sir.
share your screen.
Yes, sir. Is it visible? So is it visible?
Perfect. You're good to go. Please start.
Okay. Just a sec. Good evening, everybody. Myself, Dr. Zareen Rangwala. I'm a third-year postgraduate resident from Grand Medical College, Mumbai. My mentor is Dr. Bakshi sir and Dr. Bandarwar sir. A 56-year-old male patient who is a laborer from Bede came with chief complaints of a recurrent swelling in the right side of his face since 6 months and pain in the swelling since the last 15 days. Patient gives history of a similar swelling in the right side of his face 5 years back, for which he underwent a surgery 2 years back. Patient has now developed a swelling over the same site on the right side of his face 6 months back, which was insidious in onset and has gradually progressed to the present size. Site. After the surgery, the patient had complaints of deviation of his right side of angle of mouth, drooling of saliva, and inability to close the right eye completely. The swelling was painless to begin with, and he has developed pain over the swelling since the last 15 days. The pain was insidious in onset and has gradually progressive. It is dull aching in character, localized to the region of the swelling, non-radiating, no aggravating factors, and is relieved on taking medications. There is no history of ulceration over the swelling. There is no history of fever. There is no history of sinus or fistula over the scar site. There is no history of evening rise of temperature, cough with expectoration or a Cox contact. No history of similar swelling in the opposite side. No history of swelling in the neck, groin, axilla, abdominal pain or night sweats. No history of any oral cavity lesions, complaints of pain during deglutition, earache or difficulty in mastication. There is no history of dryness of eyes or mouth or of joint pains, no history of any bony pains, and no history of loss of weight or appetite. Patient underwent a surgery for a similar swelling over the same site 2 years back. The details of the surgery are not available. After the surgery, patient developed features of facial paralysis. Patient was lost to follow-up after the first surgery. There is no history of any radiotherapy in the past. There is no history of any other surgery or any medications. There is no history of any comorbid conditions in the patient. Patient gives history of tobacco chewing for 5 to 6 years, 2 to 3 times a day, which was stopped after his first surgery. He denies any other addictions. His sleep, bowel, bladder, and appetite habits are unaltered. His family history is unremarkable. So my summary based on history is he's a 56-year-old male who presented with a recurrent swelling on the right side of his face since 6 months with recent onset of pain since 15 days. He was operated for the similar swelling on the right side 2 years back, after which he developed features of right-sided facial paralysis. Patient was lost to follow-up. He has no comorbidities. Coming to examination, patient is conscious, cooperative, and well-oriented to time, place, and person.
No, you stop the please.
Okay.
We'll discuss the history, please.
Yes,
Okay.
sir.
Zareen, can you tell that what are the various morbidities this patient had because of the facial paralysis?
So because of the facial paralysis, sir, he was unable to close his eyes properly, the right eye. There was drooling of saliva and there was facial asymmetry, which was troublesome for the patient, sir.
And did he have any problem in the eye apart from closure of the eye?
No, sir. I asked him if he had any visual loss or any pain or anything in the eye region, but he denied. Or if I even asked if he was feeling dryness of the eye or any different sensations over his eyes, but he denies anything about that, sir.
There's no history of corneal ulceration
No, sir.
or
No, sir.
keratitis. There's no history of that.
No, sir. Yes.
And is he able to eat the foods properly?
He is able to eat food, sir. He does not give any history of difficulty in chewing of food or anything.
No, but what did he complain? What is the usual complaint after there is a
He
facial
just
palsy?
he said that the saliva keeps dribbling from the right side of his face, and he said that his facials, like there is gross asymmetry of his face. That is what his complaint was. These 3 points only, that he was not able to close his eyes. There was drooping of saliva, and there was asymmetry of the face after the first surgery.
What used to happen to the food what he was taking?
Sir, he was usually he would one would expect the food stasis to be there over the right side, but he was able to use the more like he's chewing food more towards his left side, and he was able to swallow. He was not having any difficulty as such.
Okay.
Okay. So, which are the tests you'll do to see which that facial nerve is involved? Which muscles will you test and how?
Sir, I have done the facial nerve examination in the examination part. Should I describe it right now?
Okay.
No, you can proceed.
We'll go that. Okay. You asked about pain in the ear. What are the causes of pain in the ear in this patient?
Sir, for pain in the ear, basically, I asked that in case of a parapharyngeal mass or a swelling, that would cause a referred pain to the ear. So in that context, I had asked for pain in the ear. Or
any other cause of pain, which is quite common. Have you heard of Eagle syndrome?
Eagle syndrome, sir. I'm not aware, sir.
Okay, this is calcification of the or elongated stylomastoid.
Styloid process.
Styloid process, and that impinges and causes pain. It's very common seen in ENT. In ENT.
Yes, sir.
So the facial palsy is after the surgery.
Yes, sir.
It's not related with the tumor. It's post-surgery sequelae.
Yes, sir.
Before the surgery with the tumor, his facial nerve was functioning normally.
Yes, sir. It was, sir.
Okay.
So it happened immediately after surgery, or did it happen later? We want to know, right?
Yes, sir. Sir, he said it happened immediately after the surgery, sir.
And it's not progressing?
No, sir. The whatever facial paralysis that he developed, it was the same, sir.
Why is it important to know this?
Sir, because in cases of if the primary malignancy was an adenoid cystic carcinoma, there is a perineural invasion of the tumor, so which would lead to a progressive nerve paralysis, sir. So that is.
So is it improving the nerve palsy better with time or deteriorating?
Or the same? Sir, it's the same, sir. What same? It's the same, sir.
Okay. How many months after the first surgery he noticed the recurrence or the second swelling?
Sir, he was the first swelling came 5 years back, for which he was operated 2 years back. Like 3 years after the first swelling, he was operated for the first time, and now he has presented us 6 months back. So almost 1.5 years after his first surgery, he's come to us, sir.
Okay.
So you think this recurrence is because of adenoid cystic, this involvement of nerve is only because of adenoid cystic carcinoma and any nerve involvement. Can a mixed parotid tumor also cause involvement of the nerve?
So a mixed parotid tumor will not cause a nerve involvement per se, but there could be a possibility if the nerve injury was there. I'm not saying for this patient, but there could be maybe an iatrogenic injury, or if the tumor was, the dissection was not possible around the nerve, or maybe due to that, there could be some nerve injury.
So if it was iatrogenic, as you say, when do you expect the nerve involvement to improve? What's the time period for, suppose there's an iatrogenic injury?
So for transient iatrogenic injury, the transient nerve palsy would improve over a period of at least 6 months, sir.
Right.
Okay.
Yes, sir.
Okay. So from your history, what do you think? This is a benign etiology or a malignant?
Sir, I initially considered 2 to 3 possibilities based on history. Either there was a for example, either there was a benign tumor, say like a pleomorphic adenoma, which has now maybe recurred, and the nerve injury was iatrogenic, or there could be a low-grade malignancy, which was since the patient did not follow up. So we still don't know whether the histopathological diagnosis of that tumor which was excised, and because again we do not know that whether he required a radiotherapy and which he did not take, that was also not done, sir. So either a benign has recurred as benign, or there was a low-grade malignancy and which has recurred again now. Malignancy. So these are the two possibilities I'm considering.
Oh, okay. Proceed to
On history, sir, basically.
Dr. Zareen,
Yes,
Dr.
sir.
Zareen, I know that you thought of two possibilities, but what is your actually inner inner thinking will tell me? Be honest.
Sir, actually, I have now, after I have examined the patient, so I know the
not examination, one look of that lesion.
Sorry, sir?
One look.
Sir, it looks like a malignancy, sir. Recurrence
That's
of
what you should
malignancy.
tell. That
Yes,
is what
sir.
is the actual fact.
Yes,
so
sir.
whatever be the discussion, we'll have it later. It's not common to get a pleomorphic adenoma recurrence in that
also.
way, number one.
Yes.
Every book has described, no doubt it recurs, but not like what you are seeing, number one.
Yes, sir.
So number two, low-grade malignancy or high-grade doesn't irrespective of that. So mucopodermal carcinoma is probably likely. I do not know anything about that, but what you should tell is 2 years back surgery has been done. There is a facial nerve paralysis or injury. Patient is lost to follow. Now you see that lesion. If you look at that lesion with the skin fold, like, like a hood, upper portion of the lesion, there is one kind of a skin fold. All typical of a, skin infiltration.
Yes,
this will not happen in a benign lesion. Like a
yes, sir.
pleomorphic adenoma, even though it recurs. So this is what you should tell. So first possibility is probably a malignant tumor. Doesn't matter. Don't say low grade and all. You are not pathologist at this stage. Give a chance for the examiners to ask you. Okay. You understand? It can still be a malignant pleomorphic adenoma. How can you say that it's only a other lesion? So it's a histopathological diagnosis.
Yes.
Right? So this is how you should discuss. Most probably it is malignancy, which has been removed. Now it has come back. And removed, they have taken out the nerve also. Yes, it is possible. Not that. So this is how you take, right?
Yes, sir.
What are the causes of recurrence after the pleomorphic adenoma excision? What are the various causes of recurrence?
So pleomorphic adenoma has pseudopods-like extensions. So
one. What are the other things here?
So other reasons of even if there is a complete if a complete superficial parotidectomy is not done and only an excision of pleomorphic adenoma is done, then it can recur. Or there's also a 3%, if the deep lobe was involved and only superficial parotidectomy was done, then it can again pleomorphic adenoma can recur, sir.
It can be because of spillage of the tumor at that time. When you're doing that, the spillage of the tumor is there. And if it is a multicentric tumor is there, then also you can have the, so apart from the pseudopods which are there or the inadequate margin, it can be because of the spillage and because of the multicentricity of the tumor.
Okay, proceed with your examination.
Okay. So the patient was examined with his due consent in a well-lit room in sitting position. He's conscious, cooperative, and well-oriented to time, place, and person. He's afebrile, pulse rate of 90 beats per minute, taken in right radial artery. His blood pressure is 130 by 80 millimeters of mercury, taken in right brachial artery. His BMI is 22 kg per meter square. He is averagely built and nourished. There is no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy and edema. Cervical lymphadenopathy, sir, I've explained separately. Skull and spine examination is normal. His Karnofsky performance status is 90. Local examination on inspection, the left side of the face appears normal. There is a gross facial asymmetry noted. There is loss of nasolabial fold on the right side. On inspection of the swelling, there is a lobulated swelling over the parotid region, which is irregular in shape. It measures approximately 8 by 6 centimeters in size, with a well-defined anterior, superior, and inferior borders. The posterior border appears ill-defined. The surface of the swelling is nodular. Skin over the swelling is tense and erythematous, and there is no evidence of skin breach, that is sinus fistula, ulceration, or any fungation seen. There's a linear healthy scar over the anterior border of the swelling, which is approximately 8 centimeters in length, which is healthy, and there's no hypertrophy or keloid seen. There is obliteration of retromandibular sulcus. The swelling becomes more prominent on clenching the teeth and less prominent on mouth opening. Coming to intraoral inspection, the parotid duct opening is seen and it is normal. There is no visible bulge seen in the pharyngeal walls or tonsillar fossa. No abnormality seen in the buccal mucosa, floor of the mouth, palate or tongue, and oral hygiene is poor. On palpation, the findings of inspection are confirmed. The swelling is tender on superficial palpation. There is no local warmth over the swelling as compared to the other side. It is a single swelling which is multinodular with well-defined borders and size measuring 8 by 6 centimeters. Swelling is seen occupying the retromandibular groove. The margins are well-defined in the anterior, superior, and inferior borders and ill-defined in the posterior border. The extent of the swelling is present over the right side below the ear lobule and not extending above the zygomatic arch. Inferiorly, it is still 2 centimeters below the inferior border of mandible. Anteriorly, it lies behind the ramus of mandible, and posteriorly, upper anterior border of sternocleidomastoid, obliterating the retromandibular hollow. The consistency of the swelling is hard. The skin over the swelling is adherent. The swelling has restricted mobility from side to side, and the curtain sign is present. On palpation of the right parotid duct is normal. The left-sided gland and parotid duct is normal. And on bidigital examination, the right side of the deep lobe is not enlarged. Facial nerve examination. So vision and Schirmer's test is not exactly the function of facial nerve, but I've just explained it with facial nerve examination as a complication of it. So his vision is normal in both his eyes. He has inability to raise the eyebrows on the right side, inability to close the right eyelid completely, absence of corrugation in the forehead during frowning. Bell's phenomena is present. Schirmer's test is positive. Inability to blow, whistle. Taste sensations are normal. On clenching the teeth, deviation of right side angle of mouth is seen, and loss of normal contraction of platysma while stretching of neck. So as per the Hausman-Brackman facial nerve grading system, he has grade 6 total paralysis on the right side. His TMJ joint does not show any mouth opening is adequate 4 centimeters without any restrictions. There is no other restriction of movement of jaw. Facial artery pulsations are palpable. On examination of neck, there is on right side submandibular 2 by 2 centimeter non-tender lymph node palpable with no local warmth. It is firm in consistency, non-mobile, and fixed to the underlying structure. There were no other lymph nodes palpable over the neck. The opposite parotid region is unremarkable. His systemic examination was within normal limits. So my summary is a 56-year-old male coming from Bede with chief complaints of recurrent swelling and pain on the right side of face in the parotid region. Patient was operated for a similar complaints 2 years ago. On examination, there's a 8 by 6 centimeter nodular hard swelling fixed to the skin and underlying muscle with lymphadeno present in the level 1B with features of complete facial paralysis on the right side after the previous surgery. My provisional diagnosis is a recurrent neoplastic swelling of the parotid with facial palsy on the right side as a complication of the previous surgery with clinical TNM staging T4N1M0.
Did you palpate the parotid duct here?
Yes, sir, I did, sir.
How did you palpate that?
Sir, I first asked the patient to clench his teeth so as to make the masseter muscle taut. Then I palpated the parotid line joining the tragus of the right ear till the midpoint of the nasolabial fold. So in between that, I used my index finger and tried to roll over my finger to feel for the parotid duct, sir.
It's a bidigital examination. So you have felt only with the index finger?
So this is the for the opening, the terminal part of the duct, to palpate for the terminal part of the duct, I did a bidigital examination wherein one finger was near the opening of the duct and the other finger was over the cheek, sir.
What is the length of the parotid duct?
So the length of the parotid duct is about 5 centimeters, sir.
And what is diameter?
About 0.1 to 2.5 millimeters, sir.
So 2 to 3 millimeters.
2 to 3 millimeters.
And what is the relation to the zygomatic arch?
So the parotid duct lies approximately 1 centimeter or 1 finger breadth below the zygomatic arch, sir.
And where does it open?
It opens in the buccal mucosa opposite the crown of upper second molar tooth, sir.
Okay, we are talking about the lacrimal gland. Do you know in the recent years something new which has come in the lacrimal glands?
Lacrimal glands.
A discovery which has occurred in the recent times, which has occurred probably after about 200 years.
New salivary gland.
Sorry, sir?
They found a new salivary gland.
No, sir,
Tubular.
I'm not aware.
Have you heard that? New salivary gland?
No, sir.
Tubular.
Yeah, the new salivary gland. It's a new
Clinically,
organ which has come. Yeah.
Deep lobe of parotid is involved clinically?
No, sir, it is not involved, sir. I
Okay.
was unable to.
Intraoral examination is normal.
Yes, sir.
Okay.
Okay. Sorry. You said you examined the facial nerve. Which are the muscles which you examined? First, raising of eyebrow. You did that, okay?
Yes, sir.
Which muscle were you testing for that?
So frontalis belly of the occipitofrontalis is raising of eyebrows. For
okay.
For
closing of the eye.
Orbicularis oculi, sir.
Then
So then
when angle of mouth.
Levator anguli oris, sir, and orbicularis oris.
Is oris, okay.
Clenching.
Sorry, sir.
Clenching.
Sir, when we ask the patient to clench the teeth, it is the masseter which contracts. Masseter is not supplied by the facial nerve, but we ask the patient to grimace to see the contraction of platysma muscle, sir.
Okay.
Masseter is supplied
by the trigeminal nerve, sir.
Okay. So muscles of mastication. It's a different.
Yes.
Okay. So how will you proceed further? So your clinical diagnosis is a recurrent malignant etiology.
Yes,
with
sir.
Nodal disease.
Yes,
so,
sir.
Okay. Points in favor of malignancy?
Sir,
clinical?
Points in favor of malignancy clinic. So first, based on the history of having
examination.
Examination. Points in favor of examination is that swelling is tender. The swelling is hard in consistency, irregular, with adherence of overlying skin and restricted mobility, and also presence of lymph node. So those points.
Zareen, one other question. If
Yes,
you
sir.
look at the surface with that nodular, whatever
Yes,
you
sir.
use the word, you use the word lobular. I think it's better
Nodular.
because lobular is not that good in this way. Whenever, especially 1 centimeter, such big nodules like thing which you are visible here.
Nodular.
One more important presentation you should have told probably. The surface, is there any slight reddish color there?
Yes,
I
sir.
can make out. Did you mention that?
Yes, sir. I've mentioned that the skin over the swelling is erythematous.
You can go to the picture. You can go back to the picture.
Yeah, that's so very important. What does it indicate to you? Why is that? You think it is vascularity or something else?
That picture. Next one.
This.
Yeah.
Now, what does it indicate?
See, there's some reddish here.
It indicates impending rupture.
Impending rupture, yes.
Yeah,
sir.
very important, because so you see that there is a difference
Stretched
between
out and
It's going to be skin involvement here.
Skin involvement, yes, sir.
So very important. It's skin infiltration, and anytime it may rupture. That is how it is. The manifestation of all these malignancies happen.
Yes, sir.
I was talking to you about the hood-like thing, above that one arc-like thing you are seeing above. That one skin infiltration, there's some edema just above the ear lobule there. You can see
Yes,
one
sir.
arc.
Yes, sir.
Upper, still above. The skin fold.
Yes, sir.
These are all. You were talking about sometimes
Yeah.
back, I heard as a what is that, perineural invasion. So did you look for any bony tenderness here?
Yes, sir. I did look for
Which bone? Which bone?
bone.
Which bone?
Sir, tenderness over the TM joint, over the mastoid process, and over the mandible, sir.
So mastoid process. So
Mastoid
behind,
process.
you need to look for the mastoid process there, which is behind.
Yes,
So
sir.
it's a, so perineural spread is typical of adenoid carcinoma,
Yes, sir.
right? So you should look for here related bones here, especially in this area. So that is one thing you should look for, bones as well as lymph nodes, and systemic examination in this patient is required because he has specifically has come with a recurrence with
Recurrent malignancy.
huge nodular lesion, right? Okay.
So the masseter is involved, masseter is infiltrated.
Yes, sir. I am suspecting on clinical
Masseter
examination.
muscle?
Yes, sir. On clinical examination, I am
Okay.
suspecting involvement of masseter due to restricted mobility, sir.
On clenching the teeth.
Yes, yes, sir.
Okay. Okay. How will you proceed further? What is your plan?
Sir, first, I would like for confirmation of diagnosis, sir. I would first like to investigate the patient. For tissue diagnosis, I would like to do a biopsy of the patient, preferably a USG guided FNA. And for the for the mass per se, I would like to do an MRI for the parotid region. Also, sir, actually, I would also like to do a CT scan since the node is present to look for other nodes in the neck region. I would also like to do a CT scan and would also like to do an FNA for the lymph node as well.
So why do you want to guided FNAC? There's such a big swelling.
Zareen,
Yes, sir. Yes. Yes, sir.
You answer, then Desai sir will ask you. You answer, Saji sir.
Zareen, basically, you are trying to do an MRI, you are doing to do USG, you are doing to do a CT scan. Don't you think it's too much of a luxury that India can afford? Or even as a student or a doctor, we should be somewhere rational and try to limit our investigations. We just cannot keep on doing all the investigations.
She is from Mumbai.
Don't you think? No, even if she is from Mumbai.
No, sir, because the patient has already been treated at a peripheral center and has now come to a tertiary care center. And since we do have the facilities available, that is why, and has come with a recurrent swelling. So we would like to.
Is it your hospital policy? Or why not limit to a single imaging modality like CT or MRI alone?
So if we can limit the imaging to, but or I can get an ultrasound of the neck for the nodes and an MRI for the swelling, sir, because it is a recurrence, sir, and to see the extension of the swelling.
Question. Why ultrasound guided FNA? Saji sir asked a question, answer him.
Zareen, I would like to point out, you see, basically, the more investigations we do, we always tend to get more information. There is definitely, if you go on speaking, then you can do a PET scan, you can do a bone scan, you can do a lot number of things in this tumor. But then we have to be rational, and rational according to whatever facilities are available and whatever present science indicates and supports. So you try on blurting out all the investigations. We have to be a little practical and rational. And so I think you should do only a limited number of investigations, either a CT or an MRI, and then you must support your the investigations which you are asking for.
Yes, sir. Sir, if I'm to do one investigation, then I would definitely like to go for an MRI, sir.
Okay, so you'll have to support now. Why MRI over CT scan?
What is the definite advantages of MRI over a CT?
Why MRI?
Over CT in a parotid tumor?
So MRI will delineate the soft tissue more for the soft tissue, sir. So the local extension of the tumor, I will be able to see better on an MRI, whether the deep lobe is also involved or no, and the extension into the surrounding structures. That is why I would like to prefer an MRI.
Okay. In
Also neurovascular involvement.
And
Neurovascular
neurovascular involvement as well, sir.
Perineural involvement usually.
Yes, sir.
In an unoperated case, usually for in assessing the facial nerve, MRI is better.
Yes, sir.
Okay. Any other investigations other than FNAC, MRI? Anything else you
Do
want?
you want to get a biopsy, FNAC or biopsy?
Sorry, sir.
She said ultrasound guided FNAC. She was done. She said so.
Okay. No, but why not a biopsy?
So you mean true cut biopsy, sir? Why not, sir?
I don't mean anything. I'm just asking you. See, if you are going to get some this thing, why not a biopsy of any kind?
No, I can get
Why
an
FNAC?
Sir, an FNAC has a good sensitivity results for parotid swelling, sir. So, and it is easily available, cheaper, and can be done without. So that is why an FNAC, sir.
In this patient, would you do is an open biopsy?
No, sir, I would not do an
No,
biopsy.
definitely, because it's almost the skin is about to
Yes, sir.
fungate.
Fungate, sir.
If
I
you
will not
do, okay. Any other metastatic workup you do?
Sir, on
Chest X-ray, chest CT, or anything?
Clinical examination, sir, and patient on history and examination did not have any features of metastasis. So just a chest X-ray I would any which ways do for anesthesia fitness and everything. But apart from that, any special investigation for metastatic workup at this point I would not do, sir.
What is the commonest site where the mucoepidermal carcinoma metastasis, other than the lymph node?
Other than the lymph nodes,
Usually, it's usually to the lungs.
Lungs,
usually,
chest.
lung mets are the common.
Yes, sir.
Okay.
Yes, Desai sir.
So, what is your, what is your further plan?
So my plan for sir, after the confirmation of diagnosis, I would first counsel the patient regarding his diagnosis, for what surgery are we going to perform, and also the need for follow-up that he will require. I would like to do a total parotidectomy with elective neck dissection on the right side, level 1, 2, and 3 supraomohyoid neck dissections are for this patient on the right side.
Is it total parotidectomy? Skin involved? What is it called?
Radical parotidectomy.
Radical or something more than that? What is radical parotidectomy?
So radical parotidectomy is excision of the gland with dissection, as in the nerve is transected, as well as the underlying, if the underlying muscle is involved, that is also removed.
Not that. It is usually the removal of the entire parotid with the facial nerve, that is called radical parotidectomy.
Yes, sir.
Anything more than that is called extended radical parotidectomy. This patient definitely needs a lot of skin sacrifice. Maybe it is fixed to the masseter muscle or to the digastric or part of stenomastoid. So those structures also has to be sacrificed. So anyway, it's more than a radical parotidectomy, an extended radical.
Yes,
Zareen, you said that you will do level 1 neck dissection. Level 1. You said
3.
level 1 lymph node. For this, what is the standard lymph node dissection?
No, sir. 1, 2, 3. I said level 1, 2, and 3. Supraomohyoid.
Is it safe to do a supraomohyoid for a clinically positive node? You think it's a hard node with relative fixity to the surrounding structures?
Yes, sir.
Do you do an FNAC of the lymph node?
Yes, sir. I would like to do an FNAC of the lymph node as well.
Okay. So any patient with a clinically positive node, it's better to do a comprehensive, means clearing all the levels, not limit to the supramonoid. Because parotid has a high tendency to spread to the level 5 nodes. Okay. So what is a surgery? Is it a, first of all, is it an operable disease?
Yes, sir, it is operable disease, sir.
This is operable.
Okay.
This one. Yeah.
What are the signs of inoperability here?
Signs of inoperability would include involvement of the base of the skull, pterygoid plates, or encasement of the carotids. So that would be inoperable, sir.
Okay, good.
Maybe you can always tell the decision.
Now, and as Dr. Shaji said, for all MS level, for all MS level, if a node is involved, you can just say that you will do a radical neck dissection, modified radical neck dissection.
Yes.
So you don't do selective node dissections when a clinically a node is involved.
Not radical. You have to do a comprehensive, all levels. If the chance of preserving accessories there, you can preserve. But all the levels 1, 2, 3, 4, 5 has to be meticulously cleared.
Yes, sir.
What are the various types of modified radical neck dissections?
Sir, the type modified radical neck dissections type 1, 2, and 3. In type 1, along with the removal of level 1 to 5 lymph nodes, there is, in type 1, we preserve the spinal accessory nerve. In type 2, along with the spinal accessory nerve, we preserve the sternocleidomastoid muscle. And in type 3, we preserve external jugular vein as well. Internal jugular vein.
Okay.
Sir.
Okay. All three vital structures.
Yes, sir.
Now, if you sacrifice the spinal accessory nerve, what happens?
Sir, if the spinal accessory nerve is sacrificed, the function to the sternocleidomastoid and the trapezius muscle, that is hampered. So the patient will have some weakness over the shoulders. He will be unable to shrug his shoulders, and weakness on that side of contraction of sternocleidomastoid, sir.
Okay. You think the carotids are involved here?
Sir, I don't think the carotids are involved, sir.
How would you know?
You have the imaging pictures or anything?
Sir, actually, I do not have his.
Okay.
Suppose the carotids are involved, then what?
So if the carotids are involved, then it becomes inoperable. Then he would have to go for a palliative chemoradiotherapy, sir.
All carotids involvement require palliative radiotherapy? What is abutment and what is encasement?
Abutment is just a touch, the tumor just, there's contact of the tumor over the surface of the carotid.
How many degrees involvement?
Sir, I'm not sure, but it is, I think, less than 30.
No, it's 180.
Okay, less than 180. Okay.
Arc of contact with the vessel is less than 180. Usually you will call there is no definite infiltration.
Yes.
Without any definite infiltration. Okay.
One of the fatal complications of the radical neck dissection is the carotid blowout. So what are the various ways to prevent that?
To prevent a carotid blowout?
Yeah.
Sir, I'm not aware of it. Actually.
Okay.
Carotid blowout can occur mainly because of the infection. So you have to always prevent the infection in that area. And that is why you should not completely bare. You must leave the intact sheath over the carotids. Second is that you should make your skin incision like that the angle doesn't come over that area, over the carotid. So that doesn't necrose and cause the infection. And you can use some muscle cover for that.
Muscle.
Which muscle is there?
What are the incisions for radical neck dissection? And what's the principle of these incisions?
Have you assisted a neck dissection or done a neck dissection?
No, sir, I have not.
Okay, you have not seen
Like this.
also. Okay.
No, sir.
But you
So-
must read about it, okay?
Yes,
Because,
sir.
all right, neck dissection is generally asked in your operative notes in exams, right?
You
So
read
must
about
know.
Kreil's incision, McPhee incision, Schobinger incision.
All of these, because there are certain areas in the neck where the flaps can necrose. That's why these incisions are there are so many incisions to prevent this. And of course, like Sir said, coverage of the carotid, very important here.
Yes, sir.
That's right.
Who described radical neck dissection? Any idea? Okay.
Kreil.
George Kreil.
Kreil. Yes, sir.
Okay.
You know which muscle is used to cover the carotids? Like when we are doing the inguinal block dissection, which muscle is used to cover the femoral vessels?
Sir, I'm not sure, sir. I think the adductors are used, but I'm not sure.
Sartorius.
Sartorius is yes,
Neck
the
you
Taylor's
usually use
muscle.
in the neck
You
you use the
capitis, no?
What is the other name for
scapulae or
sartorius? What is sartorius muscle known as?
So the Taylor's muscle.
Yes.
Occupation,
Sartorial means style. Okay, so it means it's a Taylor's muscle.
Taylor's muscle.
The carotid, what muscle you said, sir?
Levator scapulae or splenius capitis.
That's fine, 7 o'clock.
Zareen, now with the resection, there is going to be a defect at the neck and this thing. How are you going to plan to cover the defect?
So we can cover the defects by using flaps, sir. Either we can use the pectoralis muscle myocutaneous flap, or we can use our radial forearm flap, sir, or we can use a flap from the anterior lateral aspect of thigh, sir. These are the flaps.
Okay. In an examination, try to limit it to one option and try to stick and support the option for reasons whatever. Okay. So have you seen any of these flaps?
No, sir, I have not seen.
Okay.
Okay.
You must read about the basics of flaps. Okay, I think this is important. You're in third year, so they will ask you, these questions are asked in exams. Basic flaps for radical neck dissection for inguinal.
You can stop your flap screening, man.
Oral cancers reconstruction, right? All these things.
Okay. Yeah, MSc level you can escape by naming some flaps. They don't ask you deeper pedicle, how will you rotate the flap. Those things you need to know. But you
There's a
should
very
be
good
aware of.
book called McGregor, Head Neck Surgery. McGregor, go through that.
Okay.
That's described head neck surgery very well. McGregor with flaps.
Okay. Do you think he needs adjuvant treatments?
Yes, sir. He might require an adjuvant radiotherapy, sir.
He might, or he will
Sir,
need.
We don't know the histopathological. It will depend on the histopathological report of the excised, but mostly
no, you don't have to wait for the histopathology. Just see the tumor. It's a T4 disease.
Sir. T4 disease.
T4 recurrent tumor. Anyway, he needs, if it's a malignancy.
Yes, sir.
Most probably the histology will come as high-grade mucoepidermoid or even adenoid cystic. Most probably it's a high-grade or intermediate-grade mucoepidermoid carcinoma. That is the commonest cancer in the parotid.
Yes.
So he will, and the lymph node also. So what are the indications for radiotherapy in parotid tumors?
So indications for radiotherapy in parotid tumors, again, as you said, sir, high-grade tumors, T4 lesions, sir, recurrent tumors, as well as like for palliation, if the inoperable
Not
cases.
for the adjuvant treatment.
So
nodal involvement, multiple
nodal
nodal involvement.
Margins positive, recurrent tumors, and T4 and high-grade tumors.
Okay.
Can we take care of the facial nerve of this patient? Can we do something with the facial nerve?
Sir, we can right now, sir, if at that time only it was repaired during the first surgery, right? Now the nerve function is already gone, so we can do.
What can you do now when you plan the surgery?
Yes, sir. We can for deviation of
facial
mouth,
reanimation.
Yes, some sling surgeries can be done for rehabilitation, for the deviation of angle of mouth. If he's not able, he's not able to close his eyelid, so tarsorrhaphy or gold implants are put to for that. Otherwise, artificial to prevent ulcers, corneal ulcers, we can give him artificial tears for that.
Dr.
So,
Zareen,
yes,
suppose this person had come to you earlier
yes, sir.
with this kind of facial palsy. What could you have done? What were your options? He came post-operative after say 2 months or a month or so with this facial palsy. What could you have done?
So immediately after 2 months, sir, if it was, I'm not exactly sure, but would mostly for facial physiotherapy and exercises and the same line of management.
How do you do that? What is TENS? Have you heard of TENS?
Nerve stimulation.
Right. So what does it do? How does it act? How does it help?
Sir, I'm not exactly aware how it works, sir.
Right. It increases the nutrition of the nerve and the metabolism of the nerve, and it prevents atrophy of the neuromuscular junction. Right. So that is used till you can repair the nerve. Okay.
And out of all the branches of the facial nerve, if you have to save one branch, which one you will save?
So the branch which supplies the orbicularis oculi muscle, sir.
So which branch?
The zygomatic branch, sir.
Zygomatic. Right.
And why?
To prevent.
Why is that so important?
So because to prevent complications of exposure keratitis, sir. If he's not able to close his eyes, he's more prone to dry eyes, ulceration, and which may lead to visual loss also.
No, if you have detected that there is a facial nerve injury at the time of the operation, what can you do?
At the time of the operation, sir, we can so either if there is no segment lost, we can suture primarily. Epineurum of the nerve is sutured by using monofilament sutures. Or if there is a certain segmental loss, then we can use cable grafts and anastomose the nerve, sir.
What is a cable graft? What is a cable graft?
Sir, a cable graft is a segment of nerve which is not for example, for facial nerve, you can use a cable graft using an greater auricular nerve or a sural nerve to.
So you just call it a nerve graft. Why do you call it a cable graft? What does cable mean?
Involving all the. I'm not sure.
Have you seen a cable? Have you seen a cable?
Yes, sir.
It's got multiple wires inside.
Yes, so involving
this
the
is
entire.
So this is what we do. We take 3-4 strands of the nerves and we attach it to one end and we attach it to the other end. So the nerves are here, and in between a couple of nerves. That's a cable graft. Okay.
What was done to this patient, Dr. Zareen? Is the patient getting treated in your department?
No, sir. He was, because we were shut down for COVID, sir, we had to refer him to the.
Do you have any follow-up of this patient?
No, sir. And this actually patient didn't come here. He came 2 months before, sir. We just had clinical photographs and all for presentation, but we had to send him to a Tata Memorial Center, sir.
Okay.
Dr. Shaji Thomas and Dr. Sharad Desai, you can give the closing comments. I think we have discussed most of the possible things. And then we'll give Zareen to give a chance to ask questions if she needs to get some clarifications.
I think I will ask Shaji because I missed part of the session.
Sure, sir. Sure.
She has presented it well and answered reasonably good.
Thank you,
good, Zareen.
Thank you, sir.
Only thing you lack little practical exposure.
Yes,
most
sir.
of the things you have not seen. Otherwise, you have read everything. You have a good theory knowledge, and especially your presentation, you have described all the salient clinical findings, clinical history, everything. That is good presentation. MS level.
And I must suggest,
all the best.
I just have a suggestion that I think because of a towering institution like Tata Memorial Hospital in the near vicinity, you tend to miss out on many oncosurgical this thing. This used to happen even when I was doing my MS, because there are cancer hospital nearby, so all the cancer patients tend to go away. So we tend to find this difficulty.
Sharat
So
sir, you
have
are
to
from
go
Grant Medical College?
No, I am from Ahmedabad.
Okay.
Educated from Ahmedabad.
Okay.
So, but
Okay.
I know the problems.
Sir, also because we have like wide super specialty also in our institute. So again, all the
Yeah, that
flaps
is a
and
difference.
reconstructions will directly go under plastic surgery. So we as
But you have to go and watch that what is happening to your patients.
yes, sir. Yes, sir.
Okay, just
No, you do the resection. The plastic surgeons come to your theater and do the flap, isn't it? You don't do the resection. Then the
Yes,
patient.
sir. It is sometimes
Combined
because
operation.
they require specific instruments and everything, or if they require microscope, then a patient is operated in their OT. It is also like that.
No, you just do the
Otherwise, they have to
basics.
get their entire set and all those.
No, that's right. But you refer it just again. Next time you get the reports of what they did. That will be better. You
Yes, sir.
presented very well. Thank you, Zarin.
Thank you, sir.
And Sumati madam, your comment, madam. You are in mute mode, madam.
Shanai sir, anything?
Very good presentation, sir. Covered everything. Very nice.
Thank you, ma'am.
Thank you,
The
madam.
same problem happens to all PGs and even for us, because the specialty people's patient has to be shifted to their center, but they don't come here and operate. So
That's a totally different challenge every institution is now facing, and Bombay is having another problem of COVID
But now
still
too,
ongoing.
we have nodes, like our surgeries have come to a standstill only from the past 6 to 8 months. Sir. Our theaters are not working.
Rajgopal sir, your comment, sir.
Nothing. I think, if I'm not mistaken, she has presented earlier also in this forum somewhere.
No, sir. No, sir. Probably some other forum, not in our forum, sir. Dr. Srinivasan sir had the connect to bring Dr. Zarin to our forum, sir.
As far as the presentation is concerned, it's good. Nice way of presentation. I know the logistics of the issues of doing these cases, and in general surgery department becoming a residual surgery department, too many super specialties in the hospital exposure. But Zarin, you will get a easy good marks also if you know at least what has been done and some issues.
Yes,
I don't want, obviously we can't perfect on our plastic surgery so many hundreds of flaps, but you can expect a PMM, peculiar major myocarditis flap question in this type of patients of oral cancer and all those areas. What is called a workhorse. Microvascular surgery, not many people are doing it. So, but in the sense you need a separate setup. So, at least some fundamentals of the flaps, and if you know, you will score a little higher marks. And again, we can't expect everyone to know all about anatomy and physiology of everything now, but at least you know oral cancer is a definite short case. Parotid is a definite short case. So be thorough with the facial nerve. So obviously facial nerve reconstruction will come. If you answer cable graft and all that thing, you will get very good marks.
Yes.
So it's not that we cannot by heart and learn everything, but at least you know, okay, parotid will be asked. Now related reading, separate reading you should give for parotid, not just inspection, palpation and management. All these nerve related issues. Similarly, tongue, anatomy, physiology, something, secretions, glossopharyngeal nerve, like that. Definitely few questions will come. Chorda tympani, anterior two-thirds supply, glossopharyngeal, etc. So this is a way of reading. If you do, you will do well. That's all from my side. All the best.
Thank you.
Thank you, sir. Thank
Since
you.
I said facial nerve, can you name the canal through which the facial nerve comes?
Canal, it exits through the stylomastoid.
No, before that, it traverses in a canal, and that is the longest bony canal in the body. It's called the fallopian canal.
Fallopian canal in the middle ear, sir.
Yeah, from there to the stylomastoid foramen. Okay.
Yes.
Internal acoustic meatus.
Yes.
Sir, Anjay Kanna, sir. Sir, you are muted, sir.
So please unmute yourself. Yes, sir.
I think as Dr. Rajgopal said, that as a general surgeon, you should have a little idea about the reconstructive surgery. you know, if you get a case of the oral cancer or anything in the head and neck which is there, or now even the breast, because there's a lot of the breast conservation surgeries there. So little of the reconstructive surgery will be definitely asked to you there.
Yes.
And you should have a basic idea about that, that are you going to use a flap, or you are going to use a free flap, or you are going to put a graft in that area. And like in the oral cancer, you must have a basic concept that it is always repaired in 3 layers. You have to give the cover, you have to give the lining, and you have to give the support. So cover is the skin which is there, lining is the mucosal member which is there, and support is the bony support, either mandible or the maxilla, whatever it is. So at least that should be known, and you should know at least, like our workhorse which is there is the pectoral flap which is there. So little about that. Then the deltopectoral flap is there. These are 2 most important flaps which are there in the head and neck area, which is used for that. And then in the breast, like is little about the oncoplasty. Okay, whether it is a volume displacement variety or whether it is a replacement variety. And you should have a little idea about the rectus abdominis, transverse rectus abdominis, and the latissimus dorsi flap. So these are the at least 4 flaps I will tell you that you must have a little idea about that. So on the head and neck, pectoral, and the deltoid flaps, and in the breast, you should know about the latissimus dorsi and the transverse abdominis flap.
Yes.
Thank you.
Dr. Zarin, do you have any questions to get clarified after going through all this exam questions?
No, sir. If I have, I will message and ask.
Okay. No problem. Thank you, Dr. Srinivasan sir, for getting Zarin to us. And I should also I've been requested by the Bangalore Surgical Society. I think Karnataka entire team is hosting the Professor B. Hanumaya Memorial National Continuing Surgical Education Program 2020 from 23rd to 27th Friday. It's a week-long PG program. They have planned for a very comprehensive program. I think the entire MS course is condensed to 1 week. I think Rajgopal sir, you want to share, because Kalevani madam asked me to specifically tell in the forum.
I just want to bring the attention of all people here. More than now 30 or 35 years. This Hanumaya Memorial CME in Bangalore is almost quite a famous national level. I have gone as a PG way back in 1984-85 period. Then onwards, it's a week-long process. Sunday is usually the hands-on, all the skills-based learning, and Monday to Saturday, it is a continuous 6 days of a clinical patients. You know, is like you can call as a bonanza, like, you know, because Bangalore has an advantage of so many medical colleges. So 1 day 2 medical colleges, like that they discuss almost 6 to 8 cases per day into 6 long and short cases together. Unfortunately, because of the COVID this year, and this has been condensed, and after 5 o'clock for 4 days, obviously it's all virtual. Case discussions are there, thyroid is there, everything, but virtual. Normally, Kanagavelu is almost 400 to 500 to 600 students from all over India. They used to get a registration here. I have gone last 20 years as a faculty, but it will be worth attending. So that's what I just wanted to share. That
you can share the link, sir.
Yes, sir.
I will forward it to you.
Okay.
And I also want to inform the postgraduates. The IAGS has announced Best Thesis, that is PG Thesis Award. We have 5 awards, each of 1 lakh worth cash awards, which have been promised. And this also gives you a free registration to the national conference. And you will be able to take part in the meeting and have a connect with the academic council of the IAGS. This comprises both faculty from state level, regional level, and the national level. So I would encourage all the PGs, you can visit the website iags.in, because all of you have mostly completed your thesis or almost to complete. So a completed thesis and a letter from your HOD or your unit chief is sufficient to compete for this award. So I would say this will be a worthwhile consideration for all the PGs, because it is submission. That is all you need, because you have already done your research work. So with that information, and I also would take the permission from the faculty here. Subsequent weeks, sir, Kanna sir, we will have at 8 o'clock, sir. Is that okay, sir?
Yeah, that's fine. 8 o'clock.
Okay. So next Friday onwards, we will have from 8 o'clock. Sir, and also, sir, there have been some requests like we should have some ward issues to be discussed when we are doing the case. Maybe last 15 minutes, we have to allot for radiology, ward, and operative surgery like that. There have been some requests. I think we are covering up, sir. But then we will bring radiology and operative surgery components also. That makes the discussion more comprehensive. There have been some requests, sir. Please give your thoughts, sir. I'm willing to listen to the faculty here.
What we can do is allot only 45 minutes for 2 cases together, means 1.5 hours.
Yes, sir.
So, and then remaining 30 minutes. We
Yes,
can't
sir.
trump up everything. Maybe this Friday we will discuss say post-operative complication of something like a ward round, what you said.
Yes, sir.
One probably faculty can prepare
Yes, sir.
say thyroid, one day breast, one day some other day, and maybe one other time interesting X-rays which are commonly asked for them, like perforation or whatever it is.
Yes, sir.
Something like that we can discuss. But
so monthly once can I plan? Monthly once can I plan, sir?
That is one way of doing it.
Yes,
like
sir.
1.5 hours plus half an hour, or
Yes, sir.
or say some institution every month last week Friday.
Yes, sir.
No mixing up then.
Okay, sir.
These are my views only I am telling. So first 3 weeks, let us say you have 6 cases discussion. Every month last Friday, 2 hours or whatever time, the time is left, divide into whatever segments, instruments, specimen, X-ray or operative or ward round or whatever. I am for anything is okay.
Anna, sir, your thoughts, sir?
You know, if you see the RRC which is going on these days, the same thing which is there, that they are presenting one short case, then there is one X-ray of the chest is there, then they have one barium study is there.
Yes, sir.
Or the CT scan is there, and then they have got some radionuclide scan which is there. So these are 4 types of X-rays which are there, and then there is a ward round is there. And majority of the time, ward round which is there is always, most of the times, the trauma, or it's a biliary problem which is there. There's a biliary fistula is there, or some problem is there. So these are 2 types of the ward rounds which are there. So I think accordingly we can go for that. We keep for our cases 1.5 hours, and for half an hour we discuss one other things here.
We will probably, of course, the RRC base is for selection of the candidates for the quiz, for the something like that, for the topper, not really quiz. When I say topper of the, is a prize giving event. It is not really for this. So what Dr. Khanna said also is true. So interesting X-rays, interesting things we can always discuss, but let it be case-related common problems. That is my personal opinion. It should not be like, I am also in the ASI member, I am also a governing council, but that is a prize event. This should be the
teaching type of thing.
My personal feelings.
Thank you, sir.
Maybe then we will have the discussion pertinent to the case presented. So we will make sure they bring with their images. If they have operated, little bit of operative images also. Time being, we will try to implement that way, sir. Then over a period of time, we will see a couple of sessions how it goes. Then we will improve upon, sir.
I will just add what you said. Suppose there is a breast case, and if there is a mastectomy, we will discuss.
Yes, sir.
Candidate may not be able to get the complications of the breast following. Suppose any faculty or somebody in our group can contribute or prepare and come up with the early complication, delayed, as somebody said, intraoperative, postoperative. I have, for example, flap necrosis. So that is what amounts to ward round only, actually.
Yes, sir.
Tetany following whatever that, so postoperative, say parotidectomy, facial nerve palsy, or thyroid, like that. So something like that, we may have to work on that.
We will get more time-bound organized, as both of you have told, that 45 minutes, and then clear allocation of time for all the other things. Sir, next week I will try to implement a little different format, sir. Let me try how it works, then we will improve upon, sir. And with that note, I thank Dr. Zareen and Dr. Kapil for sharing your case. Srinivasan sir for organizing for both the cases. And I thank Professor G. Thomas from RCC Trivandrum for contributing his valuable time for today's class and sharing his wisdom. And I also should put on record, Sharad Desai sir, I just gave a message to him and he immediately volunteered. I'll be happy to participate. Being a secretary of a national society, it is a proud honor for us, sir, to be with us for the last 2.5 hours to share your expertise. Thank you, Sharad Desai sir, and we look forward for more interaction.
It's my pleasure also, sir.
Thank you. And
Thank you so much.
Thank you, sir. Thank you. Professor Sumati madam is always a silent helper. She was very hesitant to come in, but then she made it today. And Kanna sir and Srinivasan sir, I think they are like our mentors. And Rajgopal sir is always with us. Thank you, sir. Thank you, everyone. With that, we sign off this session. I thank the students who participated, and I thank the faculty who excused themselves because of various commitments which are changing. I hope 8 o'clock time will ensure make the faculty easier to join. Only request is I would request you to have your dinner on Fridays alone little early, or I think don't feel bad. You can go off the screen and have dinner, because 8 to 10 is definitely dinner time for most of us. That I am not able to find a solution for that. But let us see, sir, for a few weeks before getting into that.
Kanakwela, you may have to provide dinner to Zareen and other Kapil Manohar also.
Sure, sir. So let me try, sir. If Swiggy and other thing works, we can definitely send dinner to all the faculty. We will try, sir. We will try. Definitely within a month, we will try that, sir. I will take all the faculty's address and ensure they get dinner before the session is over, sir.
Not for faculty, PGs.
PGs will definitely, sir. Definitely. I am having a list of all the PGs who are present. I am just trying to, once physical meetings are allowed, we will definitely have them, sir. It's a pleasure to have PGs. They are so bubbly with knowledges, and I'm sure they are having a very bright and brilliant career ahead, sir. Thank you. Thank you so much, sir. Thank you, sir. Thank you, Kanna, sir. Thank you, Sharad, sir. Thank you, Sumati, ma'am. Zareen and Kapil, thank you. Bye-bye, everyone.